Yeah. We'll wait till 6:30, then we'll start our program. Yeah.
Sure.
Yeah.
6:30
So
is there.
just wait for a few minutes. Let's see how the moderator should join before we start the class. I can see one student, two students have joined. A few more to join. They will join. We cannot start our class before 7 o'clock because we have given that timing for class to start at 7. So we'll have to wait for a while.
No, it's 6:33.
Just a minute. Let me talk to Nimalu once again. Then I will ask you to start.
We have 16 participants right now.
Yeah, the Professor Dr. Shivaji Basu has also joined.
Yes, 16
I'm
participants.
waiting.
Now we have
The 17 participants. We'll start it just now, sir. Give 5 minutes time. Let other people to join a bit so that the inauguration we can start in 5 minutes from now. Hello. Hello. Nirmallo.
hello. Good evening, sir.
হ্যাঁ এই ইয়েকে জয়েন করতে বলো মলয় বেরা স্যারকে জয়েন করতে বলো জয়েন করতে বলো তাড়াতাড়ি উইল স্টার্ট আওয়ার প্রোগ্রাম nearly 20 participants have joined.
Yeah.
I think should we start our program?
Sir, let us start it.
Yeah. Good evening, my respected colleague, my seniors, and my beloved students. This is for the 4th time in succession we are conducting online mock test come class for you people so that you can perform well in your examination. At the same time, if there is any deficit in our day-to-day teaching which can be covered up over these 2.5 months long academic extravaganza, that will help most of the students for doing taking their examinations. With this small few words, I would request our President, Dr. Ranveer Prasad Singh, to welcome all the delegates, all the faculty, students, and the senior members of the society, those who have joined today to say a few words on the day of inauguration. Over to Dr. Ranveer Prasad Singh, sir, please.
Good evening, everybody. Am I audible?
Yes, sir, you are audible.
Okay. It's a great pleasure to be with you this evening, and this program is very close to my heart. The academic, I'm always interested in the academics, and most of the time I try to contribute in whatever way possible for the benefit of the students. this topic of today, there are many stalwarts, many senior people, and many most intellectuals in our society, and they will be sharing their experiences. The students will be presenting their cases and will be discussing it thoroughly so that they may have a clean cut pass in the exam and a better urologist we can nurture him and prepare him. So with these few words, I shall request Ranjan to proceed the program for the inauguration further.
Yeah. Thank you very much, sir, for your kind words. I will request our seniors present. I can see Professor Deka, PM Deka, who does not require any introduction. He is the past president of the USI, is that also very senior teacher conducting his DNB course now at present. I would request Professor Deka to say a few words and his wisdom about the class which we are planning for the next 2.5 months.
Thank you, Ranjan. And good evening to Dr. Singh,
Yes,
our
good
president. It's a very nice program that you have chalked out, and it will greatly benefit. Sorry?
Good evening.
It will greatly benefit the postgraduate students of East Zone. And all the students and faculty present in this webinar will be benefited, and I would request them to actively participate in the discussions of the cases that has been selected. With these few words, I thank you very much once again for asking me to participate in this teaching program. Thank you.
Thank you, sir. Thank you. I have seen just now Dr. Shivaji Basu, sir. Sir, can you please come up and say a few words for the students, because you are also part of our teaching in your institute for a long, long time, and you are one of the icons for the East Zone for the many surgeries.
Thank you, Ranjan. Thank you for the very kind words. But this is an extremely happy moment for inaugurating this beautiful program. And those who are participating as students, they wouldn't probably know that this is the fourth time we are conducting. And the first time, I mean, it's all Professor Ranjan Dey's brainchild, and it all went so well, and it is increasingly getting better. And last time I remember, there were participants from Jodhpur and Jaipur who appreciated the program because it was done in so much of details. And I'm sure every time the young teachers are coming up, they will take it to a new height. With that one, I give it back to you, Ranjan. Thank you very much for conducting these unique events. Thank you.
We are very honored that you have given your time for the students. Students, those who have come up, they don't know how much contribution you seniors have in the developing urology in our zone. Professor Deka, you, I will also request Dr. Ranjit Das, who is one of the very veteran teachers and teachers of many teachers. So he is also with us today. I will request Professor Das to say a few words on this occasion.
Thank you, Dr. Dey. Am I audible?
Yes, yes, you are audible.
Thank you very much. Good evening to all. It is really heartening for me to see this program is being carried out for a few years, and you are the one of the enthusiasts in conducting this program. And this program, how it helps the students, at least last year I came to know from the other students, they all are highly benefited. At that time, of course, it was a COVID period. and post-COVID. But still, this will be very good exposure for all the students, and it will help them to prepare for the coming exams. Thank you very much. Please keep it on. Thank you all.
Thank you, Professor Das. I can see Dr. Rajesh Tiwari, presently the HOD and also a participant. Dr. Tiwari, please come up with your students and please say a few words for the students, how they should prepare for their examination. What is your experience over the last few years as the examiner in this zone?
आज थोड़े अभी थोड़े ट्रांसफर दे सकते हैं सुबह मॉर्निंग में
ये डॉक्टर तिवारी, unmute yourself, please. Unmute yourself. Yes,
Thank you, Professor Day, for remembering me on the first day of this academic program. It will definitely benefit all the students who are participating in this program. And as a teacher or as an examiner, many simple things are asked in the examination. Practical things are asked in the examination, which sometimes students know pretty well, but they are not rehearsed how to answer them in a sequential manner, how to answer precisely within a short span of time, in a organized manner. That they will learn from this program, I think. So all of the students of this zone, or even from the other parts of the country, should join this program and should get benefit of this program. Thank you.
Thank you very much, Dr. Tiwari. Actually, this year we have prepared our teacher panel in such a way, both the experienced and the newly appointed teachers, those who are full of knowledge of the present generation teachers, those are welcome in this program. I can see Dr. Naveen Gupta, who few years back was a student like this, but today he is sitting on the teachers forum. I would like to hear from him how he feels about this program, because he had the exposure as a student, now he is having the exposure as a teacher. Now, what is his feeling about this program?
Sir.
Dr. Naveen.
Am I
yes,
audible?
Yes.
Thank you so much, sir. Sir, I have it has just been 3 years that I have crossed over from being a student, and it is of great help that such classes by such senior teachers of the zone is being conducted. It will be of great help for all the students for the examination purpose to gain the minds and experience of all these examiners for such a long duration, that it will help them in the forthcoming examination.
Voice is not clear. Please be louder, Dr. Naveen.
Naveen, hello, Naveen.
Yes, sir.
Yeah, you want to say anything?
Sir, I told sir that it would be of great benefit for all the students in the examination, sir, to have the experience of so many examiners who have been examiners for so long. And it will also be a great learning experience for me, because we are just starting as teachers in this Department of Urology. So thank you for including us in this teaching program. Thank you, sir.
Welcome, Naveen, in this category, but I'm waiting eagerly to hear from the most senior, one of the most senior urologists of this zone, maybe of this country, from Professor Arunabh Chaudhary. With I request you, sir, to come and say give your blessings for the students so that they perform well in their future life. Arunabh Chaudhary, sir, please. Hello.
Where is he?
Yes, he is. I saw his name once. Ruma, please tell him to join.
হ্যাঁ
Ornav
স্যার আমি
Chaudhary,
বলছি
just a minute. Just a minute, sir. We have to wait for him to join for a while.
Dr. Singh, I can see you have put on the fan. And in Guwahati, see, I have to wear my coat because it is
You are fortunate, sir. You are fortunate.
because it has been raining for the last few days, you know.
Okay.
The weather is very cool. How is Kolkata weather?
Calcutta is gradually changing its nature from autumn to
Here, hot
summer.
Summer, yeah.
So,
Guwahati also, once the sun comes out, it will be very hot.
yeah. Ruma, sir, achen? Ruma? Sir, just wait for few
স্যার
minutes,
স্যার
sir.
দেখতে পাচ্ছি না, ওনাকে ফোন করছি, আমি দেখছি।
একটু চট করে দেখো. If he cannot, then we'll have to start.
While we are waiting, can I say hello to Dr. Deka, Ranbir, and
Yeah.
Good
Nice.
evening, sir.
Good
Good
evening,
evening, Dr. Basu.
Good evening,
Nice
sir.
seeing you. Good evening.
Nice seeing you and talking to you after a long time. I think last we met in Delhi briefly.
Yes, we did. Very short.
Yes.
But anyway,
It is not only a teaching program, sir. It is the common
It's a
platform
social.
where we can meet. It's a social platform also for
Absolutely.
everybody to interact.
And this social interaction amongst the seniors, and this is also a learning lesson for the students. So only
Yes.
the
I
only
agree.
passing the exam doesn't help. To be a good doctor, you have to be a good man and a good person and have a good relation with all your friends all along this zone and throughout India. I mean, that makes you a better person.
Yes.
This is very, very essential, sir. This is very, very essential.
Yes.
Actually, there are many urologists, those who are doing excellent job, but due to lack of communication, they never come into the focus, and we cannot access them, nor do they get their due. So it is always necessary to have your presentation with the society, and society should accept you. And for that, you have to be very, very serious and sincere with your responsibilities with the society. One man cannot live outside the society unless he is actively participating in this society. His presence cannot be felt throughout the country.
Absolutely.
And
Ruma,
also
I think, yes,
we
sir.
also come to know about a young urologist teacher. They are not that we have met them, but now this is a platform we come to know all of them. And they are really bright teachers, and they are of tremendous help in the
Hello.
in the contemporary urology. Ranjit, hello.
Professor Tiwari, how is
Yes,
the preparation for conference going on?
Sir, it is going on. We have booked the venue. We have blocked the hotels. Already more than 550 registrations have been done. And I will like to use this platform also to request everybody to please register for the conference, because the early bird registration is going on and it will be continue till April 15th. So I will request all of you to use your good offices and good blessings for the conference, and convince others also within your state to register for the conference. It will be a beautiful conference, sir. We have planned many extracurricular activities by the side of the academics.
The venue is fantastic. We have seen
Yes, sir.
it.
Venue is fantastic. Very good.
Yeah.
Very just on the side of on the bank of river Ganges it is, sir.
We have seen the presentation in the EZUSI Con, and that has impressed everyone.
And
Everybody-
yes, sir. We will again circulate it in the Zoom. The detailed details about the venue.
lot of people are in two minds, but after seeing the presentation, they are so relieved in their mind, and they all decided to go. I'm talking about outside zone friends.
Yes, sir.
You know.
There are only two venues like that in the whole country. One is in Ahmedabad, Mahatma Gandhi Convention Center, and another is in Patna.
Yes,
Both
that,
are on the same similar architecture plan.
Okay, sir. Thank you very much. I think I must thank all the seniors for their active participation in the small inauguration, and gradually the number of participants from participants are increasing. It's my privilege and duty to introduce today's moderator, Professor Malay Bera, who does not require any introduction for the East Zone students and also the teachers. One of the very prominent teacher and a gentleman. First of all, the perfect gentleman urologist teacher, Professor Malay Bera, will be today's moderator for this class. And I would request Professor Malay Bera to come up and take the stage and continue the next program as per your desire and plan.
Good evening, Dr. De. Probably the time is there are a few minutes time. In the meantime, I can start and introduce the teachers and students of today's program. How many participants? And 40 participants. I think most of the students have joined and expected that 4 will join. Can I start today's program?
But before that, sir, you introduce the teachers in depth, and also our intention of today's class, what you are planning, what you expect from the teachers, and what you expect from the students, because it's the test for both.
So today's this will be the first scientific program of CME after inauguration. Today's program will be on adrenal. So the teachers are Professor Dr. Rajesh Tiwari, Dr. Krishnendu Maiti, Dr. Samir Soel, Dr. Nobin Gupta, and Dr. R.P. De. And at last, our senior most teacher, Professor P.M. Deka, will give his expert comments on after every discussion. There will be 3 cases. 3 cases will be discussed. The teachers will take the classes like crossing of the students. There are 4 students, and after each 15 minutes discussion of each case, Professor Deka will give his expert comment. And the students are there are 4 students. Students are Dr. Pathak and Dr. A. Thora, Dr. Behra, Dr. Malaka. They are from different institutes. And first of all, the first case will be on pheochromocytoma. Professor Tiwari and Dr. Maiti will take the class, and the student will be Dr. Pathak. But not the only one student, the other students, if he fails to give answer, then other students will take over.
I have a small request to the students. They should introduce themselves, from which institute they are joining this class, and we welcome all of them in today's meeting.
So may I request the students to introduce themselves one by one?
Yes, sir. Sir, myself, Vedanta Pathak, sir, from Regional Institute of Medical Sciences, Imphal.
Okay, thank you. Then.
Good evening, sir. Good evening, sir.
Please introduce yourself. Louder, please. From where?
From IPCME, Kolkata.
Okay. The next.
Good evening, sir. I am Dr. Kisle. Good evening, sir. I am Dr. Kisle. I am from Guwahati Medical College.
Dr.
Kishalay, sir,
Dr. Kishalay.
from Guwahati Medical College.
Okay.
Good evening, sir. I Dr. Kishore Behra from SCB Medical College, Kotak, Odisha.
Any other student?
Sir,
No.
Dr. Kishore Behra,
Yes, yes. You are from?
SCB Medical College, Kotak, Odisha.
Okay, thank you, thank you. Then any other student taking part?
Sir,
Malay, I would say, I would request that you do a bit of
मीटिंग
voice
में है
test.
क्या बात है?
The second
Yes, sir.
one who introduced, do the
क्या हुआ
voice
है?
test. Because the second one who introduced themselves was not clearly audible. First, third, and fourth are perfect.
अभी तो इमरजेंसी में भेजना होगा ना, इमरजेंसी हम नहीं
Dr.
लेते।
Pathak?
सवेरे भेजिएगा।
Yes,
9
sir.
बजे।
Yes. Dr. Pathak from
Regional Institute of Medical Sciences, Imphal.
Impal. Impal.
कोई बात
Yes.
नहीं है। तो अभी
Then,
इमरजेंसी में, अभी इमरजेंसी सहयोग में या
Then second one?
भेज दीजिए।
Dr. Ranjit Prasad Singh, sir, please mute yourself. Please mute yourself.
Second man,
Dr. Subhajit
second
Malakar.
student,
Dr.
Dr.
Subhajit
Malakar.
Yes, sir.
You are
Dr.
from
Subhajit for IP Junior Kolkata.
IPJMR, Dr. Subhajit Malakar.
Yes, sir.
Next.
Sir, I am Dr. Kishalay. I am from Guwahati
No,
Medical College.
is it louder, please?
So, Dr. Kishalay, I am from Guwahati Medical College.
KIKLA.
KISHLAYA.
Okay. Last is Dr. Behra, I think.
Yes, sir.
You are
Perfect,
from?
perfect.
Sir, SCB Medical
SCB.
College, Kotak.
Yes,
Yes, sir.
SCB Medical.
Sir, you can start the class now, one
Yes.
by one.
So the first case will be on the case of Pheochromoceratium. Just there will be discussion. Professor Tiwari and Dr. Maiti will be the teacher, and student will be Dr. Pathak.
Yes.
Dr. Mathi will start the case, please.
Yes.
Please start presentation.
As
Hello.
yes, sir.
Can you see the screen?
No.
No, sir.
I would request all the teachers, if they have any problem with network, they can send the presentation to our office, Nirmallo, so that he can play the presentation comfortably.
If any problem, just send to Nirmallo. Send the PPT to Nirmallo. He will present it.
Sir, already this was.
So, if Dr. Mathi, if you have got any problem, Dr. Naveen can start the presentation for us. He will play the presentation for us.
Naveen.
Naveen?
क्या बात है बोलो? हाँ बैठते हैं, 12 बजे आएंगे, 12
Naveen, unmute yourself and start the presentation. Yes.
Sir, is the projection visible, sir?
Yes.
You can make it full screen.
Yes, sir. As I am unable to share it on full screen, sir.
Even then, whatever be the size you start, you
Okay.
start the case,
When
people
you
can
start,
see.
Then the next,
People can-
yes, yes. It is visible, it is visible.
Okay.
Dr. Mathi, start.
As the adrenal cases are usually put as is the not the main case or the, so we present as short case or in the word round. So our first case is a 49-year-old male who admitted with a history of intermittent tremor, palpitation, and newly diagnosed hypertension, along with significant weight loss for the last 4 to 6 months. There is no other history of any anxiety, chest pain, or anything. No history of diarrhea, vomiting, hirsutism, virilization, or any problem like that. Past history is nothing medical or surgical history significant, only for the last 4 to 6 months because of hypertension. Patient needs 3 antihypertensives for the last 4 months for his blood pressure control. And no history of tuberculosis or COPD. Next. Only there is significant surgical history of appendectomy at the age of 22 years. So I would ask Dr. Pathak.
Yes, sir.
So from the history, you want to know patient has passed history of tremor for the last 4 to 6 months, history of hypertension, which requires 3 drug medications and significant weight loss.
Yes. So we have to ask for any history of headache, so episodic headache.
Occasional.
Episodic headache.
Yes.
Then perspiration, history of perspiration.
No history of perspiration. Why you are asking for perspiration?
Based upon the history, this patient is having tremor, palpitation, newly diagnosed hypertension, weight loss. It may be related to adrenal gland. Then that we may suspect pheochromocytoma in this patient. So that pheochromocytoma patients may present with that perspiration, episodic headache.
What is classical triad of presentation?
Yes, sir. Paroxysmal hypertension, then episodic headache, then perspiration.
Now, any elaborate history you would like to know? Or we proceed to the examination?
We may ask for any patient is having any lower urinatic symptoms.
Pardon?
Any associated lower urinatic symptoms.
Lower urinary tract symptoms, no.
Why? Why?
If it is that it may be extrarenal, also extrarenal pheochromocytoma also that may arise from the bladder.
How many times you have seen extrarenal pheo?
No, sir, it is very rare.
What are the sites of extrarenal pheo?
So extrarenal, the head, neck, thorax, abdomen, then pelvis, including the bladder.
Where in the abdomen?
in that organ of Zuckerkindle.
Where it is located?
Between that bifurcation of the aortic bifurcation and root of the inferior mesenteric artery.
Yes. What they are called? These extra-adrenal values, what they are called?
Paragangliomas.
Paragangliomas. So why you are looking for LUTs when he is not telling? Why you are going for extra-adrenal? You can have asked for more common questions. You can elaborate on the hypertension, whether it is episodic, whether it is persistent, whether it is postural hypotension, syncopal attacks. So you can elaborate on all those issues. And because it is known that we are discussing a case of adrenal, suppose we do not know what type of case it is, as it will happen in exam, you will never come to know that whether it is a case of adrenal or not. So you have to look for other collateral symptoms, which can, and other causes of secondary hypertension. You have to look.
I have a small request. Don't disclose the case we are going to discuss at the beginning. So let the case presentation come and come to the conclusion with the student. What is their diagnosis?
So with this history in background, will you like to know something more, or you will proceed for examination?
Any history of medication?
This patient is having at present 3 antihypertensive medications. One alpha blocker, phenolpheniramine, another beta blocker, and calcium channel blocker. So we proceed to the examination. On examination, his blood pressure is with the 3 medications at present. It is 134 by 86 supine and 140 by 90 in standing position. Other pulse is 96 per minute in supine and 110 in standing position. Rest of the general survey is normal.
So Dr. Pathak, I will like to remind you one thing, that before proceeding to examination, you should have asked for the, because FAO is a familial, sometimes syndromic, associated with other syndromes. So you should have asked for, and moreover, patient is relatively young. Usually FAO occurs in 5th or 6th, sporadic FAO occurs in 5th or 6th decade. So patient is in the 4th decade. So you should have to ask or for the family history and look for or ask for the in the history itself about the other stigmata of multiple endocrine neoplasia syndrome and things like that. Okay?
Yes.
Okay. Now proceed. So anything positive in examination?
On local examination, nothing significant, no positive findings is available. And on systemic examination, no organomegaly in the abdomen, and rest of the systemic examination are resuming the normal limit. Essentially, the examination point of view, normal findings, no positive findings.
What next, Dr. Pathak? Time is less. You have to answer quickly.
Yes, sir. Next, we will proceed for investigation.
Which investigation?
Sir, we have to proceed for that metabolic evaluation, like seeing the plasma metanephrines and 24 urinary metanephrines.
What you are thinking of? What you are thinking of based on history and clinical examination? What clinical entities you are thinking of? What are the possibilities?
Yes, sir.
Then you will plan investigation accordingly.
Yes.
What you are thinking of?
These are, yes, it may be a case of that uncontrolled hypertension. It may be a case of thyrotoxicosis. Then it may be a disease arising from the adrenal gland, like pheochromocytoma.
Why not essential hypertension?
Yes, sir, it is uncontrolled hypertension.
That is much more common.
So how will you exclude one by one?
Yes, sir, that uncontrolled hypertension by the general examination where we measure the blood pressure of the patient.
Blood pressure is well controlled on drugs. So suppose, as we have come to know, that it is a case of adrenal. So if it is a case of adrenal, what are your objectives in evaluation?
Sir, our objectives to evaluate whether it is functional or not. That is
Yes.
functioning or not.
And second?
And to rule out whether there is any malignancy.
Okay. So keeping in mind these two objectives, what investigations will you suggest?
So to see the functioning status, first we will advise the
First you will do the routine investigations,
Yes, sir.
whatever may be the case.
Yes.
So what routine investigations?
Routine investigation will advise
Because-
on complete blood count.
Yes.
Then sir, serum electrolyte measurements. So we'll do serum electrolyte measurements. Then one kidney function test.
Oh. Why kidney function test?
So if you are sending for 24 urinary creatinine, urinary metanephrine measurement, we have to see the status of the kidney.
Okay.
function status.
And what other purpose will it help? Where it will help?
So if we are go for any contrast
Studies.
examination, contrast
Yes.
studies, then we
Yes.
know what is what.
And uncontrolled hypertension can lead to chronic renal failure.
Chronic, yeah.
So you have to know about the serum creatinine.
Yes.
Okay. So you will do the serum creatinine, and then what next investigations?
So we'll
All these investigations are normal. Dr. Maiti.
Blood parameters are normal: urea 22, creatine 0.7, sodium 139, potassium 4.4.
What is the importance of potassium in case of adrenal lesions?
Is there any importance?
Yes, sir. There will be
What happens in Conn syndrome? What happens in Conn syndrome? What is Conn syndrome?
this primary hyperaldosteronism.
So what is the function of aldosterone?
Aldosterone causes what? Sodium and potassium.
Yes.
Increase or decrease?
Cannot give the answer. Other students may be asked.
Yes, Dr.
Okay,
Malaka.
panel.
Yes, it's in primary aldosteronism, which is a Conn syndrome. When there is a increased aldosterone, it causes sodium retention and water retention and potassium depletion. So the potassium is important in case of any adrenal lesion to look for, because there may be associated Conn syndrome which may lead to hypocalcemia.
Increase in the potassium.
So in case of pheochromocytoma, is there any relation with the electrolytes?
No, sir.
Dr. Navata?
That in case of pheochromocytoma, relation is not so indicated, but we have to do for our routine purpose as in pheochromocytoma, we need some operative intervention for which we require this. So as a general routine examination, we may require for sodium potassium. But to be specific for pheo, it is not very much important.
Dr. Pathak, next investigation.
Next investigation, we can proceed for that So computerized tomography examination, which is unenhanced computerized tomography examination.
Unenhanced?
Computerized tomography examinations. To see.
First, you will go for functional test or for cross-sectional imaging, or both at a time, both together.
First, we will go for cross-sectional imaging.
First, you will go for imaging.
No, sir. After doing metanephrine levels, then we will proceed for
What functional test you will advise?
So here we will advise measurement of plasma metanephrines and 24-hour urinary metanephrines.
Both simultaneously or one by one? Which one will you prefer first? Simultaneously both or any of them?
So urinary metanephrines, 24 urinary metanephrines.
So the last slide.
Urinary metanephrine or the term is any other?
Any more specific term?
More specific
24 fractionated urinary metanephrines.
Yes.
What do you mean by fractionated?
Professor Bera, I
Yes,
have just got the call from Professor Odun Chawla. He wants to participate in your class and he will be joining very soon to participate actively in this class. We are really honored.
Thank you.
Thank you.
So what do you mean by fractionated?
By fractionated, we measure the relative concentration of both metanephrines and normetanephrines.
Okay. And what is plasma-free metanephrines? What is the term signify free? So metanephrines are in two forms, free form and a conjugated form, conjugated with sulfate.
Yes.
So we measure free forms. Why metanephrines? Why not catecholamines?
Sir, this pheochromocytoma, there is a uninterrupted conversion of catecholamines to metanephrines. So that's why the metanephrine measurement is more.
And they are released episodic. So we may not be able to measure accurately.
Yes.
Yes. Okay. And what other tests you will perform? Only metanephrines and some other biochemical tests, hormonal tests. How you will come to know that it is PO? It may be adrenocortical tumor.
Yes.
Maybe aldosteronoma. So you have to perform all the biochemical functional tests.
Yes.
All the three. Cortisol.
And aldosterone also.
So, and aldosterone and aldosterone-renin ratio. So what for cortisol, which test you perform? What are the three tests which you perform for cortisol?
Serum cortisol measurement.
You have not come prepared, I think.
The salivary cortisol.
First test. This is number 2. Salivary cortisol. His estimation is number 2. Number 1. Low dose.
Low dose dextromethasone suppression.
Suppression test. What is the basis of this test? You should read now with full, you should know facts with the underlying explanations, because whenever
If
you will
cannot
answer,
give the answer, any of the other students can give the answer.
so these are the simple questions which you should know.
Hello, sir. This is Dr.
So-
Malakar, sir.
Yes.
Yes.
So,
Malakar,
So what are the different tests for the serum for the adrenocortical lesions?
For adrenocortical, first, I will for any means to rule out whether it is pushing or not, we have to do 3 tests. Number 1 is low dose dextromethasone suppression test. Number 2 is 24-hour urinary cortisol test, and number 3 is late night salivary cortisol test.
Okay. Now, once you have come to know with the test, what is the result indicating
Low dose.
what are the interpretation of these tests, the result of this?
So for low dose dextromethasone suppression test, the thing is, if it is a Cushing syndrome, then means after giving a low dose dextromethasone, the suppression of the pituitary will not be there. If there is no Cushing syndrome, then the suppression will be there because ACTH will be suppressed, ultimately leading to suppression of the release of cortisol from the adrenal. But if there is Cushing syndrome,
yes,
means mainly Cushing disease, I can say, because then the suppression will be lost and there will be no suppression of cortisol also via negative feedback.
Cushing disease is ACTH dependent, and
Cushing
syndrome is non-ACTH dependent.
Yes, non-ACTH.
So, Dr. Pathak, what the imaging will you perform? What is the inference from this test, Dr. Pathak?
Yes, sir. The urinary metanephrin and normetanephrines are raised here in this case.
So they are suggestive of
that pheochromocytoma.
So what imaging will you perform?
Sir, I will proceed for that CT scan.
CT scans. What type of CT scan?
Sir, first we will proceed for that unenhanced CT scan. Then after that, we will see the washout, contrast washout.
Okay. So what now? This is the CT scan.
Yes.
It is not the non-enhanced, it is the enhancing CT scan, post-contrast. So can you read?
Yes, this slide shows that large enhancing lesion in the region of the adrenal gland.
Yes.
And there is peripheral enhancement seen with a Hounsfield unit 188. That so plan between that liver and the lesion is not properly demarcated.
So this is a homous spherical, well-defined margins are there with a rim of homogeneous tissue around in the periphery.
Yes.
On the right side. So can we have the report, please?
Well-defined, solid, homogeneously enhancing mass.
It is a cystic heterogeneous mass with cystic component.
Yes.
And it is 5.2 into 4.7 centimeter right adrenal mass. Heterogeneous cystic mass.
Few more students may be involved in the answering because only 3 cases. More students should get opportunities, Dr. Tiwari.
Oh, doctor, they should answer if some first one is not available. So now, yes, Dr. Mati.
What is your diagnosis from the investigation, history, examination, and investigations?
So based upon the history and metabolic investigations and imaging, my diagnosis is right adrenal pheochromocytosis.
So there in the history there was history of weight loss. Can you on the basis of imaging decide whether it is benign or malignant?
So on the basis of imaging, we cannot decide whether it's benign or malignant.
What are the features on imaging on the basis of which you can at least suspect that whether it is a malignant?
So, if the mass size is more than 6 centimeter,
Okay.
Then if there is irregular borders
Yes.
with areas of necrosis,
Yes.
calcification,
Yes. And infiltrating into the other areas, or you can, if you can find some metastasis
yes,
to some non-chromaffin tissue organs, then you can suspect that it is a, based on imaging, you can suspect that it is a malignant. Okay. So, Dr. Maiti, you can ask.
So, any further investigation do you require, or you go for management? Anything you need? Any functional imaging is needed in this case?
So as there is
Functional imagings. Name the functional imagings in the adrenal lesions.
functional imaging, there's MIBG scan, 123 iodine MIBG scan.
What is the full form of MIBG?
Meta-iodobenzyl guanidine. Meta-iodobenzyl guanidine.
And what is the next one?
So next
Commonly
functional.
perform.
Next functional imaging.
FDG PET.
Yeah, we can go for the
FDG
FDG PET. FDG PET.
So it is, I think it is not needed in this case. It is a simple case of PO. So how will you prepare this case? What is your plan now? Will you observe it or we will operate it?
So, my plan is to operate in this patient.
So you will do the?
We have to prepare the patient for surgery.
So these patients, do they need any preparation before surgery, or you can go take up the very next day?
These patients need preparation, medical preparation before surgery.
What preparations?
So,
and why?
Yes. In these patients, we have to control the hypertension.
Yes.
So, first, we start with alpha-adrenergic blockers like prazosin, and previously we used to give phenoxybenzamide for at least 7 days. Then we will assess whether there is adequate alpha blockade or not. We can see that with the reflex tachycardia and postural hypertension. If
How many days before operation usually required for preparation?
Usually, sir, it's 7 to 14 days.
Yes.
7 to 14 days.
Yes. And before that, this patient needs a full cardiological workup.
Yes, sir.
Including echo. Okay. Because he has got hypertension for a very long time.
Suppose you have started prazosin or phenoxybenzamine, whatever, patient is developing tachycardia, palpitation. That palpitation and tachycardia is not controlled, and blood pressure still 160/90.
But then we can start, sir, beta blockers.
What form of beta blocker?
We can use selective beta blockers.
Name them.
Atenolol, sir, metoprolol.
Yes. So what is the target blood pressure which you want to achieve before operation?
Yes. Target blood pressure is between that systolic between 120 to 130 and diastolic 80.
Okay. And what preparations will you need for the OT? What complications you are expecting? What problems you are expecting the operation?
Sir, yes, sir.
For which you have to work up with the anesthetist.
Yes, sir. Interoperatively, the complications may be that severe rise in blood pressure or hypotension, and postoperatively the patient may develop hypotension.
Why hypertension?
Hypotension. So postoperatively, patient may develop hypotension.
Initially we will have hypertension or hypotension.
So initially, there will be hypertension.
So how will you control it?
So we
How
have
the
to,
anesthetist will?
yes, the anesthetist has to keep drugs such as nitroglycerin or nitroprusside available with them, or they can use that beta blocker esmolol also. Then we have to give that fluid resuscitation, adequate fluid resuscitation to the patient.
And you have to hydrate. You have to hydrate the patient
Yes,
before
sir.
operation.
Preoperatively, we have to hydrate, and we have to ask the
Yes.
patient to take salt, adequate salt.
Yes. And how surgeon can help in avoiding this complication?
So the minimal manipulation of the tumor and early ligation of that adrenal vein.
So as soon as you ligate the adrenal vein, what will happen?
There will be this hypotension.
Hypotension.
Whenever you are
Hypotension will occur. So how will you manage it?
So we have to give aggressive fluid resuscitation.
Yes.
Then we can give the inotropics.
Yes, you can use the inotropic agents. Which agent will you like to use? Adrenaline or noradrenaline?
Noradrenaline.
Noradrenaline. Okay. Now, after operation, everything is over. Where you will take the patient? To the ward or to the
No,
ICU?
sir. We will keep the patient in the intensive care unit for at least 24 to 48 hours.
For observation.
Yes.
Yes.
Then
What
we have
other
to see that.
parameters you have to see in the ICU?
Yes, sir. We have to see that
Besides
electrolytes,
blood pressure and pulse.
blood pressure, electrolytes, and sugar level. Sugar level we have to see, sir.
Why is sugar level?
There may be rebound. There may be rebound hyperinsulinemia postoperatively.
Insulinemia. Yes. That can cause. So you have to monitor the blood sugar also.
That's it.
Dr. Mathi, you can ask.
So, any special preparation this patient night before the surgery? Usually,
Night before the surgery, we can give intravenous fluids to the patient.
then no, you have to give. Proper hydration is important. That what sir is saying. 1 to 2 liter normal saline you have to get.
Normal saline. Yes.
And just before induction, any special preparation from anesthetic point of view that is requested, particularly in phacocytoma.
Central venous pressure monitoring should be done.
And also arterial line, sometimes they do the arterial line for invasive BP monitoring.
Yes.
What is the preferred anesthetic agent induction for induction? Any special, and that something has to be avoided? Any medicine? Should avoid ketamine, preferably propofol and inhalation anesthesia.
Yes.
What surgery would you open laparoscopy? What surgery would you prefer? This patient.
I'll prefer, sir, open adrenalectomy in this patient.
Laparoscopy, suppose you are a good laparoscopic surgeon. Can you do it laparoscopically?
Yes, sir. Laparoscopically can also be done.
What are the port placement? Just schematic port placement. What are this 5 millimeter, 10 millimeter port? Any other students? Any other?
Sir, this is Dr. Malaga, sir.
Yes.
Sir, depending on the location and the site of the adrenal, we have to place in this case, as it is on the right side, we will put the patient in the left lateral with right side up, and we will put a 10 millimeter camera port at around 4 finger medial, lateral and above the umbilicus. And depending on the port, we will make another 10 millimeter port and another 5 millimeter port. Our left hand should have a 5 millimeter port and our right hand should have a 10 millimeter. The 10 millimeter port we generally do at the just below the border of right costal cartilage, and a 5 millimeter port accordingly with a triangulation on taking it to be a equilateral triangle. In some cases, we require another 5 millimeter port to retract the liver also.
Some cases, most of the cases, you need liver retraction. The epigastric port.
Any advantage over the retrofluoroscopy? Right side. Any advantage? Written in book. I am telling it from the book in Campbell. Any advantage or disadvantage in between retrofluoroscopic adrenalectomy and transplanted adrenal? Particularly on the right side. So if it is small, so right side is preferable retrofluoroscopy because the adrenal is sitting behind the vena cava. Half of the adrenal is sitting behind the vena cava.
Dr. Pathak.
Okay, Dr. Maiti, go on.
Dr. Pathak.
Yes.
Dr. Pathak.
Yes, sir.
Suppose now that operation has been done, then the specimen has been sent for histopathology. So can histopathologist help you in deciding whether it is a malignant or benign?
So it is so histopathologically it is very difficult to determine between benign and malignant lesion. But one that Weiss criteria is there for pathologists. So based upon that.
Weiss criteria is for FEO.
Not for FEO, that is for adenocortical carcinoma.
Yes, sir, that is fine. Yes,
there is a pass criteria. There is a pass criteria. On the basis, there is a scoring system. If the score is more than 4, then it is one can suggest that there is a chances of malignancy, but you are never sure. That is not 100% sure.
How to be sure that
so
it is
only the presence of metastasis. Yes, that indicates that the lesion is.
Be sure there is metastasis. Metastasis, presence of metastasis is the confirmatory test for malignancy.
Yes.
How can you be sure about the metastasis? What test?
So we have to do imaging, sir, like MIBG imaging. It can determine metastasis.
So after your surgery, successful surgery, patient blood pressure has stabilized. What do you do? Follow up the patient.
Yes, sir, we have to follow up the patients. We have to do, sir, that metabolic testing after 6 months after surgery, then thereafter annually we have to do. Then we have to.
Suppose 6 months after you have done the 24 hours urinary metanephrine, still 4 times higher than normal.
Yes, sir.
Then,
we will advise the patient to undergo the MIBG scan.
MIBG scan.
Yes.
That suggests that there is some missed
lesions or metastasis.
Which one is preferred, MIBG or nowadays FDG PET?
So nowadays FDG PET is preferred over MIBG scan.
Why?
Will you like to do some cross-sectional imaging for the local recurrence?
Yes, sir. I will like to do one cross-sectional imaging after surgery. to see
That
whether
can, that can detect the local recurrence as well as catch hold of some meds elsewhere also.
yes, the surgical bed is clear. or not.
If that doesn't detect, then MIBG scan will definitely help. Definitely help. So how long you will do the follow-up?
So 16% of patients, they develop recurrence after 5 years. Then there is chance of recurrence up to 15 years also.
So,
To follow up.
so how long you will follow up? Ideally lifelong, at least 10 years.
Yes.
How will you follow up? By annual?
By annual that metabolic.
By chemical test and if biochemical tests come out to be positive, then cross-sectional imaging.
Cross-section.
Dr. Tiwari is requested to see the chat box because there is some participation from Kochi. One of the students from Kochi has participated in this class. He has put up his views. Please check the chat box.
Okay. Now, Dr. Mati, will you like to ask something more?
Regarding your metastatic workup, you said that FDG PET is nowadays preferred. My question is why FDG PET is nowadays preferred over MIBG? And when MIBG is the investigation of choice, not the FDG PET. Any special conditions? Where FDG PET is not preferred, but MIBG is
in cases where only there is only that rise in norepinephrine levels.
Any familial condition?
Congenital-Lindau syndrome.
MEN2.
MEN2
syndrome. What is MEN2?
Multiple endocrine neoplasia syndrome.
MEN2, what are the components? Okay. You, in the investigations, you ask for CT scan. For adrenal, what is the CT scan special investigation? Especially you have to mention that for adrenal, what are the CT components?
Adrenal, we have to see the Hounsfield unit. CT.
Hounsfield unit of non-contrast.
Hounsfield unit of the unenhanced. So if the Hounsfield unit is less than 10.
Why you want to see the density of the, pardon?
So to differentiate between benign adenoma and pheochromocytoma.
So what criteria is there to differentiate between the adenoma and functioning adenomas or carcinoma or METs?
Yes. So in benign adenomas, the Hounsfield unit would be less than 10. And in
why it happens so?
They are rich in lipids. There's lipid.
Where lies the lipid?
Lipid.
Where is the lipid?
Outside the cell or inside the cell?
Intracytoplasmic.
Intracytoplasmic.
It is inside the cell. And if it is outside the cell, what it will be? What entity it will be? If it is outside the cell?
Lipid.
Yes. Then what do you call it? Which can be well diagnosed on NCCT. It is myelolipoma. So what special things you have to write to differentiate more between the two in the CT?
One, you have told that in non-contrast CT, any special thing you have to mention? The cut should be 5 millimeter.
Yes, sir. Cut should be 5 millimeter.
Not the 10 millimeter or 7 to 8 millimeters. Okay.
Yes.
And anything special on the contrast film? You have
Sir,
to mention?
yes, sir. 1 minute post bolus, then 15 minutes washout.
How much?
Sir, 1 minute post bolus.
15.
15 minutes, sir.
Yes.
Washout. How much percentage?
Sir, more than 60%.
Yes. Yes.
More than 60%.
So
What is
what absolute or relative? Absolute or relative?
Sir, absolute is more than 60%.
more than 60%?
Relative,
Suggest what?
So you have to read all those things. When
Okay.
you go back
I think-
from here.
Sir, you
revise
have
all
completed. Sir, you have completed. I think the time is coming.
Time is up.
Time is almost up. If you have any question, please
Okay.
ask.
Then Dr. Deka will pass the expert comments. And yourself.
Dr. Deka, sir, any from your part, special any tips to them and special comments or any question if you want to ask to them, any specific question. Professor Deka, sir.
Yeah. The teachers have done a great job, number one. And they have asked almost all the questions that has to come in the picture. I think all the students tried to answer, and it was very encouraging that they have studied. And from my side, I just want to highlight few points. That pheochromocytoma is a very interesting and important tumor for urologists as well as the endocrinologists. And it is said to be a great masquerader. Sometimes it is very difficult. And along with the paragangliomas, what is called the PPGL. So this tumor requires great degree of clinical suspicion and proper investigation. And some of the times, there may not be any typical symptoms of pheochromocytoma, particularly when the gland is non-functioning. Sometimes there is no function of the gland. And I would suggest that there was I would like to quote, there was a symposium in 2005. Before that, there is no proper blockade, alpha blockade. In that symposium, it was decided that any tumor suspicious of pheochromocytoma, the catecholamine testing should be done. Following that, and in the 1950s, I think 50 or 51, the mortality rate of pheochromocytoma was about 50% during surgery. And after that, when there was alpha blockade and gradually the beta blockade added with good care, anesthesia techniques, it has come down to 0 to 0.2% now. So it has improved a lot, but still one has to very, very carefully select the cases, and preoperative preparation is very important. Preoperative preparation of the cases are very important. And I would just like to say that we must do the arterial pressure control properly preoperatively. And then we have to do the reversal of chronic circulating volume depletion that is to be corrected preoperatively with intravenous infusion of saline and also oral increase of fluid at least 1.5 times more than what normally is taken, at least before surgery, 3 days before surgery. But alpha beta blockade is to be done at least before 2 weeks. And also have to take care of the heart rate and arrhythmias during surgery. So for that, we have got drugs like the beta blockers and calcium channel blockers, and also cardiac function status is to be seen properly. And so the echocardiography is mandatory for all these cases. And with this, care and preparation, now the mortality for few surgery has come down very significantly. And for the diagnosis part, you have already discussed all the things, MIBG scan, FDG, PET, CT and all. In this, I would like to say that for extra-adrenal detection of tumors, pheochromocytomas, I think MRI is better. MRI will give a better result in CT scan. And also for malignant, if you suspect malignancy, then FDG PET will be helpful. That's what I have to, add to the discussion. And if there is anything anybody wants to ask, they can ask. Thank you.
Our next case will be presented by Dr. Naveen Gupta. And
Sir, can I say something?
Yes, of course.
Dr. Samir here. Yes, one question to the participants. Just how to know the alpha blockade is adequate?
Any of the participant who can give the answer, how to know the alpha
Sir,
blockade is sufficient?
to know the adequacy of the alpha blockade, we have a Roizen criteria. It consists of various components. The BP should
just,
be.
Just tell me what you will see. What symptom, what question you will ask the patient to confirm that adequacy of the alpha blockade.
The patient is the typical symptoms of hypertension, episodic headache. It has been veered down.
Just wait, not to waste time. Let me tell you clearly. There are two symptoms you need to know. One is control of hypertension, that is postural hypertension will start. Second is nasal stuffiness. Nasal stuffiness is one of the critical points, or if that is present, then you must know the alpha blockade may be sufficient. And another point, can you manage a case without giving alpha blockade? What is the data says?
Sir, recent studies suggest that it can be managed. But sir, in our institute and
it's not practiced in India, but few centers abroad, they are practicing this protocol. Okay.
Yeah. With the permission of the chair, I would like to add one thing. A particular situation, a few with pregnancy, what is to be done? In early pregnancy, suppose 24 weeks or so, you prepare the case and control the blood pressure with, because the mortality is very high, maternal mortality as well as fetal mortality is almost 50%. But if you can do a proper alpha blockade and prepare the case, you can do you can continue the pregnancy, and after proper preparation, you can do a laparoscopic removal of the tumor. And if it is late pregnancy, you have to do a elective cesarean section along with removal of the tumor at the same time if possible. So that is the protocol for pregnancy.
Okay, sir. Thank you, sir.
Thank
We
you.
can start our next case. Dr. Gupta, you please start presentation. And Dr. Somerswain will be along with you. The student will be Dr. Kikli.
Is the screen visible, sir?
Yes, yes, yes.
Sir,
Yes, yes, please continue.
Yes, sir. So I begin with the history. A 46-year-old gentleman complaining of left flank pain for the last 3 months. The pain is dull aching, mild to moderate in severity. It is relieved with medication. There are no aggravating factors. It is non-radiating. There is no history of fever, associated LUTS, vomiting, hematuria, dysuria or lithuria. There is no history of headache, syncope, dizziness, perspiration, chest pain and palpitation.
But that's not.
So, participant, please introduce yourself. Who will be in this session?
Sir, I'm Dr. Kisle. I'm from Guwahati Medical College.
Okay, what do you feel from this presentation till now?
Till now, sir, there may be some causes for the left flank pain. I have to
Yes.
ask for.
What,
Yes, sir.
what is coming to your mind for this history? Be shortcut and fast.
Pardon, sir?
Anything that you would like to come to some sort of the differentials, Dr. Kishle?
Yes, sir. The patient is having left flank pain. I have to ask the severity
Yes,
of the pain.
Yes, yes, then.
Okay, I'll go ahead with the history. There is no associated lump in the abdomen. There is no bone pain, loss of appetite, loss of weight, discoloration of the eye, no history of cough, trauma or instrumentation.
This in this case, it may be a case of since the patient may, I have to ask the patient about any. Sir, you have already given a history of hypertension, diabetes, is there or not? Sir, any history of?
From till now, what is coming to your mind? As
Sir, it may,
urologist, just tell me what. Yes.
sir, it may
yes,
be a. Yes, it may be of renal origin. Sir, pain may be of renal origin since it is located in left flank pain. The patient is having.
Okay. Okay.
Till
okay.
now, I can think of any renal calculus or any renal associated anomaly as a
Renal calculus
pathology.
disease.
Renal calculus
Okay.
disease. Yes, sir. And sir.
Maybe fuse obstruction, maybe renal mass, maybe stone.
Yes,
Okay.
sir. Renal. It may.
So what do you want now?
Sir, I have to ask for the further history of the patient.
What further history you just said?
Sir, if the patient is having hypertension.
Yes, those have been given already.
There is no history of diabetes or hypertension. There is no history of cigarette smoking, no history of alcohol intake, and he does not have a history of asthma or COPD.
With
What
this,
else would you like to know? Anything more you want to know in history?
So is there any history of
Be quick, I think.
already, sir, taken fever is not present, sir. Pain, nature of the pain I have examined.
You,
Sir, I would
look,
like
actually now, just a minute. You should be very precise. Actually, now, almost this will take more time to complete this case. The time is fixed, so better to go forward. Just think, what do
you
want
want anything else?
no, sir. I would like to proceed with the further examination.
Okay.
So
Local
till now,
examination.
till now, you think this pain and everything is to be a renal origin.
Yes, sir.
Cause may be different. Okay, next.
Okay. The patient also does not have any drug history. There is no similar family history, and the patient has not undergone any surgery in the past. So we should move to examination, Dr. Kishla.
Yes, sir.
Okay. Here is the examination finding. The general survey: patient is conscious and cooperative. Blood pressure is 130/90, and the general survey is essentially normal.
Yes.
What next?
Sir, after general survey, I would like to proceed for the systemic examination.
What systemic examination?
I would like to start with this per-abdominal examination in this patient, sir.
So this is the abdominal examination. The patient is examined in broad daylight in supine position.
Almost normal.
Yes.
And inspection is almost normal.
Yes.
On palpation, the superficial palpation is normal. Deep palpation, abdomen is soft, non-tender, and there is a vague mass palpable in the left loin, with ill-defined borders and smooth surface moving with respiration.
Yes.
There is no organomegaly. Hernial sites are intact. Genital examination is normal, and on percussion, there is no evidence of free fluid in the abdomen.
So, sir, till this, with this, I can understand that this is maybe a origin of renal pathology, maybe of renal origin, or it may be a origin of suprarenal, adrenal mass. It may be adrenal origin. Sorry.
Okay. So what are the features you are supporting in favor of renal origin?
Yes, sir. In this, after deep palpation, there is a vague mass palpable in the left loin, so it may be of renal origin. It moves with the respiration, so it further.
Yes, one is location of the mass.
Yes.
Second is moves with respiration. What else?
Sir, and sir, apart from that, there is ill-defined borders, but since ill-defined borders are there, so it is a mass which is situated in the retroperitoneum most probably, because any mass that is superficial, the borders will be more defined.
So can it be splenic mass? Colonic mass?
Colonic mass, sir, will be sir.
Okay, insulation below the rib, that is positive in this case,
Yes,
probably.
so
that test has to be done. Okay, clinically, finger can be incidented below the river.
So splenic mass is ruled out.
Margin. Yes. Okay. So your provisional diagnosis will be confined to renal and adrenal origin
Yes.
till there. Okay. Anything you want to confirm? Be quick. Do you want to confirm anything?
I would like to check for any F2 ballot.
One question is coming to the chat box. Is ballotable. Would you like to see ballotability in this type of situation, or when you what is your opinion regarding ballotability in this type of situation?
Sir, any mass which is palpable, any renal mass which is palpable, we should better avoid doing ballotability tests, because
No. Actually, Actually, the mass is palpable means palatable word is gone. Actually. So when the mass is not palpable and you are suspecting a renal mass, then you do palatable test to ensure it is a kidney origin. So if mass is palpable, then palatability is not a question. Second is renal angle tenderness. We have not asked for that. Okay, that is another point to complete the examination point. Okay. So it is negative because it's not mentioned. So assume is to be negative.
No renal.
So what do you want next?
Further, just to complete examination or to check for any other.
Tell the point, not to. Hello,
Yes,
you are just describing.
I would
Just
like
tell the
to
point. In the
I would like
examination
to
also, just for information for all residents, the way you are describing from this, I am going actually better to avoid this type of
I
wording.
think for work also you had to travel.
No, first year.
Please mute. Please mute. Okay. So better to directly go to the point what has been asked. So what next you want?
I'd like to examine.
Directly
I would like to
go
go. I'd like to examine the central venous system, cardiovascular system, central nervous system, and respiratory system.
All the remaining systemic examinations,
All are
CVS,
normal.
CNS, respiratory are normal.
Yes. And so with this,
So what would be your differentials till now?
till now, this is a case. This may be a case of renal mass, or sorry, sir. Starting from the palpable lump, it may be a case of renal origin. That may be of. It may be a case of renal so any calculus disease that is obstructing the renal pelvic vessel system, and there is the renal kidney is palpable. It may be a hydronephrosis. It may be a chronic case of pyonephrosis, or renal calculus disease, or it may be a renal carcinoma, or it may be a case of adrenal origin.
Basically, you think that the disease is either of renal or suprarenal origin, and you want more markers. There is not much in the history till now.
Yes.
Okay. So what do we need to move to next? What do you want next?
So I would like to perform routine examination, starting with the urine routine examination and urine culture examination.
You want
and then
just a minute. At this point of time, actually, directly go to ultrasound, because ultrasound is an extension of clinical examination. So better in OPD, suppose this patient is coming to OPD, you will not wait for all the investigation to come and you will be planning your diagnosis. Better in this type of situation, directly go for ultrasound, then simultaneously you will go for other routine investigation. This should be the sequence. Bera sir and Dekha sir can opine regarding this.
No, in examination, better to tell the urine examination and baseline hematologic and others. And then, of course, the physical examination comes, then he can tell that physical examination comes side by side with the ultrasound examination. Because when we are going for physical examination, we also take the help of ultrasound. And but side by side, the basic investigation will also be sent.
Okay. I totally agree with Dr. Swain that after clinical examination, you have got a suspicion of a abdominal mass, whatever it could be. Next thing is to be done is the ultrasonography, which is easily
it comes with the physical
available.
examination.
Yeah, which is easily available, and it will give a lot of information to you so that you can go for a further investigation in the right direction. That's what I feel. After the physical examination, they should go for a sonography.
Ideally, it should be done. But in the hospital practice or others, we write down all the basic investigations along with the ultrasound.
Yeah, that is true. Okay. But ultrasonography is a must. It is to be done.
Okay. Thank you, sir.
So what about ultrasound? Just show the ultrasound.
So read the ultrasound. Hello.
Yes, sir.
Dr. Kishla.
Sir,
Please read the ultrasound. If you don't have any clue, then directly ask the report. If you
sir,
don't
actually,
understand
sir,
the
this looks like a there is a hyperechoic component. Actually, I am not able to make out the which is the liver any.
Okay.
in-
We'll
Please
move
see
to
the
report.
chat box.
another as rightly pointed out by Theory sir. I must tell this thing. This examination should be complete with Ignos portal and DRE examination. This has to be mentioned also. Which people have missed this. Since other systems are normal, we have skipped it, but it has to be mentioned here.
Also spine,
Okay,
including
please tell
spine
the-
also. Yes.
Yes, sir. Please tell the ultrasound report, if at all you can read.
This is the ultrasound report, Dr. Kishla.
Yes, sir. It states that the large, well-defined solid space of fine lesion, 13.5 into 11.7 centimeters, upper pole of left kidney. It may be a adrenocortical carcinoma or renal carcinoma. Now I can correlate.
So, what do you
What will
want
do?
next?
So since we have completed with the ultrasound examination, sir, we are left with the urine routine examination and blood examination.
This is the urine routine.
Urine routine, there is no any, the RBC is 0 to 3 per high power field. So there is no any hematuria. And the pus cells are also 2 to 3. And the albumin is trace. So, sir, we there in this space, and at least we should rule out any the renal mass which is causing hematuria is at least ruled out, and the albuminuria is also rules out the renal origin that may cause albuminuria in the patient, and the culture is sterile. So
what other investigations do you want?
The routine blood investigation, complete blood count.
What routine blood?
Yes, complete blood. It will include complete blood count, serum electrolyte, sodium and potassium, and serum creatinine also.
Sodium is 137, potassium is 4.2.
So I would
Tell me first. Don't wait.
yes, sir.
What do you want next?
So with all these in mind, I would like to proceed with contrast imaging, CT scan with intravenous urogap.
Okay. Before that, would you like to go for any other blood investigation, or you are complete with this?
The serum calcium should also be done. Serum calcium can also be done.
Suppose calcium is normal. You assume calcium to be normal.
Yes. So, sir,
my question is,
yes,
what other blood investigation will choose on the basis of your preliminary ultrasound diagnosis? The ultrasound is showing it may be a RCC or maybe adrenal mass. Okay.
Yes,
sir. So what other blood investigation should be done along with this routine investigation?
Sir, keeping
or you will do this specific blood investigation after doing CT scan. What is your opinion?
Sir, in my opinion, I would like to proceed with CT scan first.
Then you will decide further blood investigation.
Yes, sir. Further.
Okay. That's fair enough. No problem. If at all, what other blood investigation will like to do?
So keeping in mind the background of adrenal cortex.
Tell me the investigation,
Yes,
not to
so
this.
I would like to proceed with serum metanephrine, sir, to rule out serum cortisol, 24-hour free urinary cortisol, 24-hour urinary metanephrine, and
so grossly we will like to know any test related to adrenal part. Second is related to paraneoplastic syndrome. Okay.
Yes, sir.
Okay. So you want to go for CT scan first, then you would like to know the other investigation. Okay.
Yes, sir.
Sir, please show the CT scan report.
Dr. Kishler, we have a series of CT images. So once you are done with one image, let me know. I will go to the next image. You will see all the images and then comment. Okay, we have 3 or 4 images. You see all the images and then comment. So should I change?
Yes. Yes, sir.
Okay, so these are all the 4 images that we have. So now, if you want any specific image, let me know. Otherwise, you start commenting.
So this is a contrast enhanced CT scan of abdomen and pelvis, in which I can comment about that origin of the mass is adrenal, and the mass is and comment about the size. The enhancement is present. The wall is irregular at and so there is some presence of some necrosis with heterogeneous enhancement.
Anything else?
And sir, I would like to check again, sir, sir, plain film, if there is any presence of calcification or not. Actually,
we don't have any plain.
So, and sir, due to the mass, the kidney is pushed downward.
The kidney is displaced.
Okay, then you tell them with just the impression. Just tell the impression only.
So the CT scan impression?
No, I am asking the candidate. Resident, please tell the impression.
The left side SOL of adrenal origin with heterogeneous enhancement on contrast and presence of necrosis with irregular border, and there's no the margins are irregular at some borders with irregular margin and borders.
Any idea about the size of the mass in relation to the kidneys and with the USG that you have already had?
Sir, this mass may be, sir, approximately 14 centimeters.
Okay, so it is bigger than the kidney.
Yes, sir.
So this is an adrenal mass suspected to be malignant.
Malignant, yes.
And there is okay, suspected to be malignant. So at this point, what extra blood investigation you want, and why?
Sir, I would like to know about the functional status of this mass for further planning of the management of the patient.
You want functional studies, okay?
Yes, sir.
So tell me the basic functional studies you want. Enumerate only.
So basic, start with the serum cortisol.
Okay.
Pre-metanephrine, 24-hour urinary cortisol,
okay.
Serum aldosterone, serum late night salivary cortisol level, and for cortisol we also give on overnight dexamethasone suppression test we perform.
Okay. Okay. Why you want to know the metanephrine level? What history and clinical features suggest you to go for metanephrine test?
Sir, in this case, on history basis, there is no any sign present
So
that.
nothing is suggestive. Nothing is suggestive to be case of you. So do you dispense with methamphetamine, or you want to do this one? Methamphetamine should be done or not? Yes or no?
It should be included in the examination, sir. Because, sir,
Yes, yes.
there may be some
Should be included.
variant of the pheochromocytoma that are not clinically silent. Yes.
Okay, no problem. So you want to know, suppose this is clinically it's not supposed to be case of pheochromocytoma.
Yes.
What else is coming to your mind? What else? What extra diagnosis is coming to your mind?
Apart from pheochromocytoma, it may be looking at the size of the mass and the
Yes.
presence of necrosis and the margins.
Just tell the diagnosis,
yes,
not to describe.
it comes. It may be as adrenal cortical carcinoma, sir.
Okay. Can it be myelolipoma?
Sir, myelolipoma, as seen in the enhancement, the contrast enhancement field, sir, it was written 84 HU was there. So the myelolipoma, sir, most of the times it's less than 10 Hounsfield units.
Okay. So that is one point. Another, anything else?
Sir,
Yes, it is
myelolipoma.
heterogeneous.
Yes.
Mostly homogeneous. Myelolipoma
Yes,
is
sir.
mostly homogeneous.
Homogeneous and
This is
dark.
heterogeneous. Margin is irregular. This is more towards malignant lesion. Okay.
Yes, sir.
What are the functional abnormality occurs in case of adrenocortical malignancies?
So the patient.
It arises from which area of adrenal?
Cortical areas, cortex of the adrenal.
Cortical area.
Yes.
So what will be the abnormality in the hormonal level or functional level?
It will be mainly of the, sir, aldosterone level will be increased.
There are three layers, no? 3 layers of cortex. What are the 3 layers?
Sir, glomerulosa, fasciculata, and reticularis. Sir, glomerulosa. Yes, sir.
So accordingly, all 3 can be deranged.
Sir.
Okay.
Yes.
So cortisol can be deranged, aldosterone level can be deranged, or
sex drive. Dihydroepiandrosterone.
Yes, all 3 can be deranged.
Yes.
Okay. So suppose it is involving the all the cortex. So all will be deranged. Yes or no? Can it be possible? Or this patient may present with specific like Cushing syndrome, Conn syndrome, or virilization?
Yes, sir. All 3.
All 3 can be present, or it will present individually. Means it will affect only specific organ.
No, sir. All 3 can be present, sir.
Okay. So these are the reports that has been shown to you. Is he and just comment, not to describe?
All values are normal.
All values are within?
Normal, sir.
Okay.
Sir, can this patient is having any problem with aldosterone level? Yes or no?
Yes, sir.
What abnormality? If patient is having aldosterone abnormality, what will be the biochemical derangement? Potassium level will be low.
Potassium level will be
case,
low. Yes, sir.
In this case, potassium is normal. So aldosterone level probably is normal. Okay.
Yes.
So next is cortisol level. Cortisol level seems to be normal or it's abnormal? Seems to be normal.
Normal.
And what DHE? Yes.
DHE.
Tell what one.
83. It's
Okay.
normal.
So what else you want now?
What comment can you make regarding the functional status of this tumor?
This tumor is after metabolic program. This seems to be non-functional. adrenocortical carcinoma.
So,
Can you tell me the adrenocortical carcinoma? Just
No,
tell me
sir.
the name.
I can, sir, looking at the CT scan, it suggests
Okay, okay,
it's not confirmatory till then.
okay, okay. So what next you want? Your evaluation is complete or you want something else?
I would like to
That is-
plan. No, sir. Evaluation is complete, sir.
Your evaluation is complete. You want to plan for surgery?
Is there any indication of biopsy?
Sir,
Yes,
From this
pre-operative
growth?
biopsy.
yes, sir. Pre-operative biopsy can be done, but in this case, sir, I would like to proceed with the surgery, sir. But
where would you like preoperative biopsy?
sir, if I am suspicious about any metastasis that is to the adrenal
You
from
have
any
not,
other side,
but you have not done metastatic workup till now. You have told your workup is complete.
the most
What are
of
the
the
disadvantages of the biopsy of adrenal?
the most common site for adrenal metastasis is renal, and then other is lung. So we have seen the renal part. There is no any carcinoma in the the abnormality in the renal imaging. I would like to proceed with the chest X-ray.
Chest
Okay.
X-ray is normal.
You will go for metastatic workup. Metastatic workup is normal.
Yes, sir.
What are the disadvantages of doing biopsy in adrenal? Why you are not doing biopsy regularly?
The most commonly, sir, the biopsy yield of the adrenal is not.
Number one, yield. Then
Yes, sir.
what are the other
And
disadvantages?
So there are various complications that can happen with the biopsy, sir.
What complication?
Sir, hemorrhage can occur. Most common is the hemorrhage.
Anything else?
Apart from that, although we have completed the functional status, it seems to be non-functional. There may be some silent adrenal entities that after biopsy, the patient may land up in clinical hypovolemia, and sir, the patient.
So you have to exclude pheochrocytoma correctly before doing biopsy, and maybe pneumothorax also may be there.
Yes, sir, pneumothorax and hemothorax. Yes.
Is there a
And
threat of
splenic
needle
injury
tract
also
seeding?
can be there.
Is there a threat of needle tract seeding?
Yes, sir, chances of needle tract feeding is also there, sir. But it's very less.
So where would you like a biopsy?
Sir, any case, as told, it may be a metastatic, in which I'm suspecting metastatic cause. So any case of familial.
What do you mean
adrenal...
by metastatic cause?
Yes, sir.
What do you mean by metastatic cause?
So metastatic from any organ to the adrenal, sir.
So you are suspecting adrenal mets.
Adrenal metastasis. Yes,
Secondary,
adrenal mets. Yes.
secondary is in mets and
Secondary.
primary. So you are telling if it is secondary adrenal, one is primary adrenal with mets, second is inoperable mass. These are the three conditions you can think of.
And
biopsy.
also, if you cannot,
familial
if you
condition.
cannot identify the origin of the growth,
yes.
suppose it is a so large growth, you cannot tell that whether it is really adrenal or anything or kidney or something else. Then to know the origin of the growth, you have to do the biopsy. But it is usually we avoid the biopsy. Okay, please.
If it is unresectable, then can biopsy is the indication?
Yes, unresectable, you can do biopsy.
Okay, then tell me what next you want to do. You want to intervene now, or you will do some other test or other intervention? Directly go for surgery?
Yes, sir. Plan the patient for surgery.
What surgery you want to do?
Sir, since this is a large mass, more than 13.
Tell me directly
sir,
the answer. No,
sir, I would
no
like to
explanation.
contemplate, sir, open. Yes, I would like to contemplate open adrenal procedure, sir.
Open?
Open
Adrenalectomy.
adrenalectomy, yes.
What incision you will give?
Thoracoabdominal, sir. 10th rib cutting. Yes.
10th rib cutting.
Yes.
Okay. Okay. What extra? Any other incision you will prefer?
It can be, sir, retroperitoneal approach also.
Retroperitoneal approach.
Yes.
It's a big mass retroperitoneal approach. Okay. Bilateral chevron incision can be given? Yes or no?
Yes, bilateral chevron incision can be given.
Midline can be given?
Midline extending to yes, a midline can be given, but it will be difficult.
Okay, so you want to do thoracoabdominal or bilateral chevron? Okay.
Yes.
Okay. So do you think this case you want to know for biopsy and preoperative any sort of neoadjuvant chemotherapy, if at all you think it to be a malignant lesion? What is your opinion? Would you like to go for preoperative diagnostic biopsy and pre-op neoadjuvant chemotherapy? Is it recommended or no?
Neoadjuvant chemotherapy can be given, sir, but in this case, sir, it will be better to contemplate the surgery. Since
What is the cornerstone of treatment? Surgery or chemotherapy?
So surgery is the cornerstone of the treatment.
Yes, neoadjuvant chemotherapy is not recommended in adrenococcal carcinoma. Okay.
Yes.
The primary modality is surgery.
Surgery.
Okay.
Yes.
What difficulty you will face? What difficulty you expect in this case?
Sir, first, starting with the approach, it will be very difficult, sir. And sir, due to the
one point is splenic injury. Avoid splenic injury. Second is injury to tail of pancreas. And before doing this type of case, you must clearly take consent for nephrectomy, because this is a large mass and any large adrenal mass lesion, consent for nephrectomy should be taken along with this. Okay.
Yes.
Okay. What type of adrenocortical carcinoma? What is the pathophysiology or what is the pathological variant? You know. Vera sir, are you we are late or we are on time?
I think time, there is time. 5 minutes you can.
Okay, okay, sir. So what are the pathological variant you know? So, okay, no problem. Do you feel any treatment decision or difference in treatment with adrenocortical carcinoma variants? Yes or no? Tell me, not to be quiet.
The variant, we have to go for surgery.
Only pathological variant in this case, it leads to the prognosis of the patients regarding its early metastatic lesion. There is no change in management. Okay.
Yes.
You have told one thing related to evaluation with some familial lesion. You have uttered one word, familial. Okay.
Yes, sir.
Yes or no? Yes. What familial cause you want to mention?
In this case, sir, Barth-Hogg-Dubé syndrome, sir, has to be kept in mind, sir.
Okay. Anything? Any other familial lesion, familial syndrome?
The MEN1 syndrome is also, sir, present, sir.
But adrenocortical carcinoma usually.
Adrenocortical carcinoma.
Yes.
What are the two commonest syndromes?
Familial, yes.
The Barth-Hogg-Dubé syndrome and
Lee-Fraumeni syndrome.
Lee-Fraumeni and Barth-Hogg.
Okay. Okay.
Lee-Fraumeni and Beckwith-Whitman syndrome. These are the two common most common syndromes involved. So you have done an excellent job. You have taken out successfully this tumor and send it to your pathologist. So will he be able to help you in finding out whether it is benign or malignant and how? Got my
Looking
question,
at
Dr. Kishler?
yes, so histopathological features will be
How? What histological features? To establish whether it is benign or malignant. Because as of now, with our metastatic workup, we did not find any other sites of metastasis. So we have to define benign or malignant from the tumor itself.
the presence of necrosis on the gross.
One more case left.
Presence of necrosis, nucleus atypia.
You know of any criteria?
Criteria has already been told in last case.
Last case, it was
The
already
past
mentioned.
criteria, sir, PS criteria.
No, past criteria is for few.
Few.
Yes.
This is the V's criteria.
V's criteria.
Yes.
So there are 9 criteria.
9 out of 3 should be. Yes.
Involving mitosis and invasion, and presence of how many is essential for labeling it as malignant.
3 or more than 3, sir.
3 or more of 9.
Yes.
Okay.
Okay. What extra? Suppose this is come out to be adenocortical carcinoma. Margin is positive in the medial aspect near the tail of pancreas. What advice you will give to the patient?
The patient has to be started. Yes, the patient to be started.
Tell me. On
Chemotherapy, yes, sir.
What are the agent you know?
Sir, it includes 4 drugs: mitotin, cisplatin,
Yeah.
etoposide, and doxorubicin.
Okay. What is the result? What is the success rate of chemo?
And,
Okay. What is the 5-year survival, overall 5-year survival in case of adenocortical carcinoma?
less than 30%.
Around 50% actually.
Yes.
Large mass, if as the size grows, the survival, overall survival actually decreases.
Yes.
Okay. If it's
We are
more
going
than
to end of this discussion. Just few questions,
okay,
just
sir.
1 or 2 questions you ask.
Yes.
Follow-up you can ask.
No, sir. Almost done, sir.
Sir,
Almost
just the
done.
last
Okay,
question.
thank you, sir.
Sir, just the last question, sir.
So finished.
Yes, sir. Yes.
So we can start the next. Dr. Gupta?
Yes, sir.
We can start the next presentation?
Okay, sir. Deka sir would be.
Yes. Professor Deka will
I
give
think,
the expert comment.
No,
Sir.
it's all right. I think the case has been presented nicely and discussed the all aspects. But the thing is that I would like to say that it's a very rare tumor. It is not very common. 1 to 2 per million population
Yes,
is
sir.
the common case. And in different age group, I think in childhood, there is a peak. And at the age of 45, 40, there is another peak for this tumor. And females suffer more.
Okay.
And as far as I will not go into much detail, but the investigation, I think one MR angiography should be done, just to see whether there is any thrombus in the vein going to the IVC before surgery. And open surgery is the, I think, best possible treatment for large masses. Small ones, one can go for laparoscopic surgery, but it has been said that peritoneal seedling is much more in case of laparoscopic surgery. I don't know whether it is true or not. Maybe for small tumors it will not be, but if it is more than 6 centimeters or so, there is possibility of peritoneal seedling. And if it is a large mass, open surgery is the best possible thing. And chemotherapy, I don't think it helps much unless it is ACTH dependent. There is a drug now which can be prescribed. Otherwise, non-functional, which is about 50% of the tumors are non-functional. It doesn't work. And less than 50, I think another 50%, about 40 to 50 may be functional, and there will be some Cushing's in about 25 to 30%. Cushing's with high realization, some 10-15%, and also Conn's disease, aldosteronism in some of these cases. We have to remember all this in assessing case of adrenal carcinoma. Thank you very much for giving me this opportunity.
So thank you, sir. So we can start the next presentation by Dr. Rajendra, Dr. R.P. Roy. This start presentation, I shall be with him. And students will be Dr. Behra and Dr. Malakar. Any of the other student, one can, if cannot give the answer, other student can give the answer.
I think participation should be more. They should interact, you know. They're
Yes,
not interacting. Okay.
Shall I start?
Yes, start.
So this is the third case of today's meeting. So who is the candidate?
Candidates are Dr. Malakar and Dr. Behra.
Okay. So it is a 32-year-old lady presented with dyspepsia for last 1 year. She is known hypertensive. She consulted a physician and an USG was advised. So this is the USG report, USG film.
Students, what the students, please.
Anything would you like to say?
Sir, first I want to know the history more.
Is it okay. So do you want to know the ultrasonography report?
So first I want to know more history, sir.
Oh, okay.
He
So
wants more history.
Okay, I tell you with this presentation, can you guess what is the case? There is a specific term in adrenal.
So by
Incidentaloma. Okay.
Sir.
He's
So
asking
there-
about the finding of the USG. Can you read the USG?
Yes,
Yes, sir. It is showing some hypoechoic lesion in the bottom of the swan field. Size, it's an anechoic lesion, size around 2 to 3 centimeter with a well-defined capsule. And slightly arrow mark is well-defined capsule with a kidney just below it.
Okay, so the report is 3 centimeter hypoechoic but solid mass superior to the upper pole of the kidney. So can you guess the case?
Yes, sir.
What is your guess?
Sir, if it is a cyst, so it may be, sir, adrenal cyst.
No, it is not
or
cyst. It is a hypoechoic
it
but
is,
solid mass.
Sir, it may be, sir, angiomyolipoma. Sir, it may be, sir, myelolipoma.
Okay.
Or it may be, sir.
So what else you want to know?
Adrenal adenoma.
Okay. Okay. Anything else you want to know?
Sir, I want to know the proper size with all dimensions, medial, lateral, anteroposterior aspect of that lesion, with, sir, functionality of the mass by knowing metabolic workup. And firstly, I want to know its.
You want to know about anything about the history or any examination or?
Sir, duration of that symptom.
That is 1 year.
And sir, associated, if I'm thinking about adrenal lesion or pathology in adrenal, I should ask about the hormonal symptoms like palpitation, anxiety, and, sir, tremor.
Okay. So there is no weight gain or loss, no osteoporotic problem, no recent infections or tingling sensation in extremities, no diarrhea, constipation, no hirsutism, no perspiration, no feature of hypokalemia. So actually the problem is dyspepsia and without any other symptoms.
Sir, as the presented with a history of dyspepsia and we have diagnosed by USG it is a case of incidentaloma,
Yes,
and
it is
by
a
seeing
adrenal
all
incidentaloma.
and by
Then-
seeing all the other history, we can say that there may not be some functional components. So it may be a non-functional incidentaloma.
Can it be a functional incidentaloma?
So if it is a functional, then means, symptoms related to the particular
It always
hormone-
that it is always that functional adrenal tumor with symptoms.
No.
Asymptomatic, incidental can be functional. Incidental means asymptomatic. Okay. So incidental can be functional or not?
Yes, sir. In
Yes,
around
sir.
10 to 11%, it is usually functional.
It is functional.
Okay. So can be functional.
What is the definition of incidentaloma, Dr. Malakar?
Yes.
What is the definition of incidentaloma?
So incidentaloma can be defined as any mass of the adrenal that is discovered.
Any mass of?
Any mass arising from the adrenal whose size is more than 1 centimeter and is discovered on USG findings not related to the
USG?
particular cause, means imaging findings.
Imaging
Which
finding.
imaging? Which imaging?
So in this case, we can say CEC.
No, definition. I am asking you about the definition. This is the
More than more than 1
finding
centimeter.
of unsuspected mass in the adrenal found
Cross-sectional
in
image.
Incidental on
cross-sectional
cross-sectional
imaging
Cross-section imaging
Done
for other for other cause.
for unrelated
for-
cases.
Process.
Sir.
So what are the different components? If you find incident, what is the probability of the different lesions? You see, you don't know whether it is adrenocortical or it is aldosteronoma or it is, what is the percentage of probability of the different lesions?
So it
Sir,
may
metabolically
Dr. Kishore, you
active,
tell me.
11%. Sir, actually, it's depend upon, sir, metabolically active is usually 10 to 11%. And sir, in 7% case, it's usually malignant, 5 to 7%.
What are the different components of different pathological terms? Tell us the pathological terms.
Sir, cortisol producing tumor, aldosterone producing tumors, sir,
How many? How many percentage? How much?
All these included to
Tell
10
me
to
what is the percentage of aldosterone Con syndrome in case of the incident tumor?
So
What is the percentage?
1%.
It is
1%.
It's very, very rare. So which is the common?
So cortisol
Sir,
secreting
cortisol
adrenal.
producing adrenal.
So cortisol producing and the pheochromocytoma are the common.
Sir,
So what is the percentage of pheochromocytoma in incidentaloma?
So around 5%.
5%. Okay.
5%.
Okay.
Okay,
So-
Rajendra, go on. Go on.
Yeah, go on. So what else you like to know? So this is the presentation. Anything? Anybody?
Sir, I would like to know about whether the patient is having other causes, means other any drug history is present or not, or whether patient is having any other symptoms.
Okay, so past history, there is nothing significant past history. In drug history, patient only take antihypertensive because he is known hypertensive. So he is on medication. There is no cigarette or alcohol intake history or any comorbidities. And she has no similar complaint in her family. She has not undergone any surgery in the past. So this is all about history. Anything else?
Sir, if she has history of hypertension, so I want to evaluate the more about hypertension, sir, like cardiology evaluation.
Evaluate or you
and
want to
any-
know inquire? It is history or want to know investigate? On
Any history
or
of
on
any sir, history of any hypertension got
Oh.
treated before it. Any hypertension treatment, any
Hypertension is
episode
for
of renal.
6 months.
And
on
sir, any
single
episode of
medicine.
renal vascular hypertension, renal vascular hypertension, is there any relation to it? Renal vascular hypertension.
So
Or
what
there any
question
aldosterone
you want to-
producing? Sir, aldosterone Con syndrome, is there any possibility of Con syndrome?
how will you know on history whether it is a hyperaldosteronism or it is because of renovascular hypertension?
Sir, whether
Sir,
there is
only
the patient is
investigation.
pigmentation or not, the patient, if the patient is having hyperpigmentation, then we can say that there may be chance of aldosteronism, hyperaldosteronism.
Okay. And so if there
there
is
any
associated
postural
symptom of aldosteronism, then you might think of that because of this hypertension because of aldosterone.
So in Cone syndrome, what are the typical symptoms are found? In Cone syndrome, primary hyperaldosteronism, what are the typical symptoms are found? Maybe
Sir,
found, may not
hypertension
be.
with hypokalemia. Hypertension with hypokalemia.
Symptoms, not the biochemical assessment.
The patient may produce with hypertension, may have hyperpigmentation, may have hyperpigmentation.
Symptom, not sign. Symptom means the complaints of the patient, not the sign. Hyperpigmentation is a sign. It's not a symptom. It can be symptom, and a patient can say, but Sari is asking about the symptom.
Sir, tachycardia.
Okay.
And sir, and due to water retention, there may be facial edema or facial puffing.
Weakness, the
fatigue,
needs and respiratory distress, weakness.
Respiratory distresses.
Thirst, increased thirst. All these are the symptoms.
Increased thirst. Sir.
Yeah. So this is all about history. Anything would you like to know, or should we proceed?
Sir, any drug history?
Drug
About
history
any
antiplatelet
or anticoagulants?
No, there is no history of any antiplatelet, anticoagulant, or any other medicine except single agent for hypertension.
Just want to know the drug that she is taking for the hypertension.
He is taking amlodipine 10 milligram for last 6 months.
So now we like to proceed for further.
Sir, for the blood investigation and urine examination.
Investigate. Don't you want to examine the patient?
Yes, sir. General survey and related examination.
So what examination first? General survey, okay. So on general survey, patient is conscious, cooperative, well-oriented. There is no pallor, icterus, sinuses, clubbing, or any enlargement of the neck vein or neck gland. His blood pressure was recorded 150/90 and pulse was 18 per minute.
Okay, sir. Sir, any significant abdominal findings? Sir?
No, this is general survey. Is complete, or you want to know anything about in general survey? This is all about general survey I have to convey. Now, if you want to inquire something, you can ask.
No, sir, general abdominal examination.
So general survey is completed.
Sir, Sari is asking pedal edema.
The skin, whether means in the general survey we can find about hyperpigmentation, and another thing is edema, and that we can see.
Okay, not mentioned. There is no edema, there is no pigmentation. As such, there is no sign.
Then we should proceed for the systemic examination, for abdominal examination.
Per abdominal examination, abdomen soft, no organomegaly or any mass palpable. Bowel sounds are normal, hernial orifices are normal. Other system like respiratory systems, cardiovascular system, and CNS system is within normal limit. There is no important finding to say.
Sir, any renal angle fullness, any
No, there is no renal angle fullness or anything in the abdomen.
Any bony pain, any vertebral pain?
There is no pain. Patient has no, actually, patient symptom is only dyspepsia. There is no other pain. And there is no elicitation sign, there is no tenderness, anything.
Okay, sure. Then we will proceed for ultrasound examination to know to extend the physical
Ultrasound examination. So ultrasound I have already said. So this is the ultrasound. And the report is 3 centimeter hypoechoic but solid mass superior to the upper pole of the kidney.
Okay, sure.
So
Sir,
what is your provisional diagnosis now?
Sir, is like that I said, sir, it may be, sir, left adrenal angiomyolipoma or myelolipoma Sir,
Okay, till now,
left
can you
adrenal
summarize?
adenoma.
Can you summarize till now? Can you summarize?
Sir, 37-year-old lady having complaining of
32-year-old, okay.
32-year-old lady is complaining of dyspepsia for last 1 year, and no other significant history, and on evaluation, sir, and non-case of hypertension for 6 months,
Yes.
to control with a single medication, and on examination no significant finding, and on evaluation of
The blood pressure is
evaluation
150/90, it is significant. No, so it is not control actually. Patient
Sir,
is
it is not
saying
controlled
blood
with
pressure
one
is
medication.
controlled on medication, but we check that is 150/90, so it is not control at least.
And sir,
And
on examination, all systems are normals, and all system examination, including abdominal, abdominal examination, everything is normal.
okay, so
So
the case summary has been done. So what is your provisional diagnosis? And what could be the
Sir,
differential diagnosis?
sir, provisional diagnosis is left adrenal incidentaloma.
Okay.
And sir, provisional diagnosis, I will put, sir, left adrenal myelolipoma or left adrenal angiomyolipoma.
Okay.
Sir,
Okay.
left adrenal adenoma.
So angiomyolipoma or myelolipoma are hypoechoic on ultrasonography?
Sir, there are hypoechoic. There are fat content tumor, there are hypoechoic.
So on ultrasonography, it is hypoechoic but solid mass.
Adenoma can be, sir, adenoma, adrenal adenoma.
Adrenal adenoma. Okay, fine. Anything else? Okay, so how will you proceed now? Yes?
Sir, upper pole renal tumor. Upper polar renal as well.
That can be if the ultrasonography has misdiagnosed as the adrenal, it can be. But usually,
So how
generally,
will you proceed? He's telling how will you proceed? What next?
Sir,
What will you do?
I will go for a routine blood examination with a kidney function test, urine examination. Because we need the kidney function test, because in this case we require the urea creatinine for doing the CECT adrenal protocol.
Okay, and why the urine test?
Urine test to rule for any UTI or its presence or not.
Is there any symptom of UTI?
No, sir.
No, sir. So it is a 32-year female with only dyspepsia, and all ultrasonography there is a adrenal result. Do you know? Do you routinely do the urine test for this patient? Anyway, if you go for to check the UTI, then you can go for urine routine, not for
You can
culture.
do routine examination of urine, of course, but not the culture. Okay, all right.
If the routine suggests, then you can proceed further. Okay, the routine test, which is here, you can see the hemoglobin is 12.4, total count is normal, platelet count is normal, urea is 21, creatinine is 0.6, LFT within normal limit, sodium is 136 milliequivalent per liter, and potassium is 2.5 milliequivalent per liter.
The patient is having low potassium.
Yeah,
so the patient is having low potassium, hypokalemia. So by only seeing this report, we can say that there may be any hyperaldosteronism syndrome related to hyperaldosteronism.
It can be hyperaldosteronism. Anything else?
Sir, uncontrolled hypertension with low potassium, we may suspect a primary hyperaldosteronism.
One thing, and anything?
Sir, you can do metabolic workup like aldosterone level and aldosterone renin ratios.
Okay, anything else?
And sir,
Or
more
only that?
characterization of, sir?
Yes? No.
You can cross-sectional imaging.
For special biochemical test, only aldosterone is to check for aldosteronism, or anything else also?
Or you will do CT scan before that. What will you do?
Sir, first we will do biochemical test, then we will do CT scan.
So biochemical test, be specific. Which biochemical test?
First is screening. So for screening, we will do aldosterone renin ratio and the plasma aldosterone concentration. And then we can go for further confirmatory test.
Okay. So the serum aldosterone is 22 nanogram per ml and aldosterone to renin ratio is 32.
Yes, sir. So by seeing the screening test, we can see that aldosterone by renin ratio is more than 30. So it is significant, and serum aldosterone is also more than 20. So it is significant.
So what does it suggest?
So it suggests primary hyperaldosteronism. Primary or secondary, that we will further find in the next investigation.
Okay. What is the next investigation? Do you like to know?
Sir, I would like to do some sodium challenge test or food recognition suppression test. Sir.
Sodium challenge test and
food recognition suppression test.
To know
Before that, you don't want to get the CT scan?
Sir, yes, sir. Cross-sectional imaging, sir. Cross-sectional imaging with adrenal protocol, sir.
So imaging, want to know imaging and any other metabolic worker on this investigate before the aldosterone. Would you like to exclude pheochromocytoma or not? Because patient is a 32-year-old lady along with hypertension, and you can see a adrenal SOL which is 2.8 centimeter.
Yes, sir.
If you get any incidental, what biochemical test will you do? Special biochemical test. What are those?
So when we get an incident, first thing that we have to rule out that whether it is body cell producing or not. For that, we have to do 3 tests. Number 1 is overnight dextromethasone suppression test. Number 2 is 24-hour urinary cortisol
for
test.
screening, do you need all the 3 tests or
no, sir.
only one of the 3 tests?
One of the 3 tests. That is low. That is overnight dextromethasone suppression.
So which one will you do?
The overnight dextromethasone suppression test, sir.
That do you want to know? Want to do? Okay.
Yes.
Okay. Then
which dextromethasone suppression test? Low dose or high dose?
Low dose.
Low dose. 1 milligram.
What do you mean by low dose?
Sir, 1 milligram dextromethasone should be given in between 11 p.m. to 12 a.m. and the next day morning in between 8 a.m. to 9 a.m. we have to take the blood cortisol. We have to take the blood and see for the cortisol level. If it should be less than 1.8 nanogram per deciliter.
One is the low dose dextromethasone suppression test. Any other test?
Sir, for incidental or as
yes.
For incidental.
You are dealing with incidental, no? You said that.
Yes, sir.
Okay.
Then we go for now number 2 is aldosterone ratio.
Plasma metanephrine. Plasma metanephrine. Plasma metanephrine and 24-hour urine metanephrine.
Means plasma-free metanephrine, isn't it?
Plasma-free metanephrine and 24-hour urine fractionated metanephrine.
Both.
Plasma.
Then you need.
For screening,
These are screening, so you should do either one of these 2.
Which one?
Plasma-free metanephrine.
Plasma-free.
Why?
If I tell that urine, will you agree or not? So what are the advantages and disadvantages of plasma and urine? What are the advantages of taking plasma? What are the disadvantages and what are the advantages of taking urine?
So plasma is more sensitive.
More sensitive, number 1. Then?
Sir.
Then?
Sir, easily available, and it is more
easily
to
available.
collect 24 hours.
Which one is easily available, urine or blood?
Blood, sir, blood.
Blood is easily available.
No, actually,
sir, for urine we have to collect for 24 hours. Sir,
you
urine
just
we have to collect for 24 hours.
No.
You just tell the advantages of blood, advantages of urine. Just tell 1, 2, 3.
First, tell the blood.
You told that in blood, what you told?
More sensitive.
More sensitive. Then
more sensitive, more specific also, sir. 99%.
Specific.
Okay.
Yes, specific. More specific. What are the disadvantages? What are the disadvantages?
Cost is higher.
Cost are variable, difficult to take. You have to take in supine position. In different positions also it differs.
Yes. You have to
And what are
time
the
in.
disadvantages? What are the advantages and disadvantages of urine?
Sir, urine is disadvantage is we have to collect for 24 hours.
Yes.
One is
Anything?
collection. Second,
Second, it
what
is
is cost is very low. Cost is very low, and there is no variation because you are taking full time.
In
Sir,
24 hours.
over 24
There
hours.
is no diurnal
Sir.
variation.
24 hours.
But
Then,
disadvantage is
And slightly
than
more
3, as you said.
less sensitive specific than plasma.
so it depends on which one is available in the center. Number one.
Yes.
Number two, cost factor. So you can take
Sir.
urine, you can take also blood. But in case of the child, in case of the adult person, they're difficult. In child, it is very difficult to take urine. Very difficult to take 24 hours urine. So you have to think all those things.
And
Consider all
another
those
point
things.
is in CKD patient, urine is not reliable.
Yes, in CKD patient, how will you take urine? Okay, all right, go on.
All right. So screening test has been done. Okay. And this is your report. You can see the metanephrines are normal limit. Cortisols are on normal limit. So now, what is your diagnosis?
Sir, it is a primary aldosteronism, sir. Aldosterone secreting
You
cortical
want a
adenoma.
CT scan or not?
Sir?
Do you want a CT scan
Sir,
or not?
Sir, CT scan with adrenal protocol, sir. Cross-section image.
Okay, so what is adrenal protocol?
Sir, it is usually done for adrenal. First, we have to do, sir, enhanced plain CT scan. Then arterial phase, then venous phase taken at 70 seconds after contrast injection, 3.5 ml per minute. Sir?
Gas phase, 70 seconds, and then?
Sir, then delayed phase taken at 15 minutes.
15 minutes, okay. To see what?
So, to see the washout of the relative, absolute and relative washout of the contrast, to know that it is either, to diagnose is a lipid-rich adenoma or lipid poor.
Okay. So you can see the CT. It's a 2.8 centimeter suprarenal mass. Hornsfield unit is 9. And what's
Sir, it is as it is. Sir,
yes,
as it is Hornsfield unit less than 10, I can discuss it a lipid-rich.
Unenhanced Hornsfield unit. Or
Sir, it is less
non-contrast.
than 10 means. Sir, plain film less than 10 means it is a lipid-rich adenoma. Sir.
Okay. And washout studies absolute washout is
Sir,
more than 60%.
It also more than 60% is also indicate lipid-rich adenoma.
Now tell me what is your diagnosis?
Sir, left adrenal adenoma.
Left adrenal?
Left adrenal adenoma called aldosterone secreting left adrenal adenoma.
So what is that called?
Sir, Cohn syndrome, sir.
Cohn syndrome. So what is the difference between Cohn syndrome and primary hyperaldosteronism?
Sir, Cohn syndrome is usually idiopathic.
It's adenoma.
Sir, it's adenoma.
In primary hyperaldosteronism, it is a adenoma producing, then it is called Cohn syndrome. But if it is a adrenal hyperplasia or something other reasons, it is not called Cohn syndrome. Okay. So Cohn syndrome has a specific diagnosis. So primary hyperaldosteronism produced by a adenoma.
Sir.
Okay.
Sir.
Mera sir asks, sir.
What is the specific test for me? If it is a primary aldosterone, is a hyperaldosteronism, then what is the specific biochemical test? Particularly for lateralization. It's a very important lateralization. Which one is functioning, which one is less functioning, more functioning?
Sir, it's usually unilateral lesion, sir.
Yes.
Sir, it is only on
Sir
left side.
Is asking the difference between the primary hyperaldosteronism and Cohn syndrome. Cohn syndrome is actually lateralization has done. Okay, because it is a adenoma producing tumor. So if it is a left adrenal tumor, then left adrenal producing
even
tumor.
there may be suppression, even if it is Cohn syndrome or hyperplasia.
So if it is a hyperplasia, then what should be done?
So we have to do the venous sampling, the adrenal venous sampling. For that, we have to put two catheters, one at the IVC and
What is the
at
idea
level
for
of
venous sampling?
To see the lateralization of the tumor.
Lateralization. So which adrenal is actually producing the aldosterone?
Yes, sir.
Why?
Yes,
Because
sir. Which adrenal is producing the aldosterone?
Saying the left adrenal is hyperplasia or left adrenal there is adenoma. Then why do you want to do a lateralization? You got my point.
So in this case, we don't require, because in this case the pathology is specific.
Then what are the indication of venous sampling?
So bilateral adrenal hyperplasia.
Okay, number one.
And then
what?
Sir, in confusion about cross-sectional imaging,
No.
if you are unable to,
If this CT scan suggests that hospital index is 20 or 30 and absolute washout is less than 60, so this is not adenoma. Then
atypical adenoma.
you have to be, yes, atypical. Then you have to do a venous sampling, or if the tumor is less than 1 centimeter, then you do not know.
Yeah.
So actually CT scan cannot lateralize which adrenal is producing aldosterone.
So which vein has sampled? Has sampled from which vein?
sir, one catheter we have to put at the IVC, and another 2 catheter we have to put at the level of the renal vein. Then we have to see the level of cortisol. Cortisol at the level of the vein and IVC. Then we have to monitor that whether this cortisol level is adequate or not. If it is adequate, that is, if the ratio of the particular renal vein by IVC cortisol is more than 1.1, the range is between 1.1:1 to 5.1, depending on the corticotropin stimulation test. If it is okay, then we can take. If it is higher or lower than that, then we have to discard it. Following that, we have to now see the aldosterone. Aldosterone of a particular site by cortisol of that site divided by anticortisol of the opposite side divided by cortisol of that side. The ratio should lie between 1.1 to 2 and 1.1 to 4, and that is also depending on the corticotropin stimulation given on. By that we can lateralize.
So this is a adrenal adenoma producing aldosterone. So how will you manage the case?
sir, as it is a functional tumor, sir, I will, sir, go for surgery, sir.
It is functional tumor. You have already seen the reports. This case, okay, not ifs
This
and
case, I will
buts.
go for surgery, sir. Surgery, sir.
Surgery.
Surgery means laparoscopic left adrenalectomy.
Laparoscopic left adrenalectomy. Why?
Sir, it is a small tumor around 3 centimeter with not involved to adjacent organ with well delineation. So I will go by laparoscopy with the adrenalectomy.
You want okay. So how will you prepare the patient?
Sir, as he is CG hypertension, his history of hypertension, I will prepare 2 weeks prior to with adrenal protocol as in pheochromocytoma with alpha blocker, then subsequent beta blocker with pre-op hydration and saline loading, then with
Preparation is like pheochromocytoma.
Sir, as he is hypertensive, so I will according to plan
He is
for
hypertensive, but the reason is different. It's not because of not because of metanephrines.
So we have to evaluate the patient and we have to preoperatively manage the
you have to control the hypertension. You can take the advice of
cardiologist.
In this case, which drug?
Sir, it is better to give potassium sparing drugs such as spironolactone or epinephrine can be used.
Okay. So okay, you have to first control the hypertension and the potassium supplementation.
Sir.
Yes, potassium supplementation.
Potassium sparing antihypertensive.
Okay. So after controlling the hypertension, you will proceed for surgery.
Yes.
Sir.
So your plan is laparoscopic adrenalectomy on the left side.
Sir. Left side.
Okay. So what is the position of the patient in the operation theater or OT table?
Sir, it is usually right lateral position with after general anesthesia with patient in right lateral position with left side up. Then my camera
Okay.
port will be around umbilicus around.
No, the position is completed. Only lateral position. Anything else?
After general anesthesia with a patient in right lateral position with sufficient padding around leg and scapular area.
Will you like to break the table or not?
Yes, sir. We have to put the patient in the right lateral and we have to put the
That
we
is
have to
according to
put the
convenience of the
patient at the
Uh-huh. One by one. Can you tell one by one?
so we have to put the patient in the right lateral position, and then we have to keep the patient in means the kidney bridge should be kept just beneath the pelvic bone, so that we can break and we can flex the opposite side. Means if you are putting the patient on the right side, then right side dorsiflexion should be done, and the right leg should be flexed and the left leg should be extended, and pillow can be given in between that, and it should be 90 degrees. Some 85 to 90 degrees. The patient should be positioned.
The patient position should be 90 degree always.
So according to surgeons,
according to surgeon preference, and usually a bit obtuse angle. Okay, not at the right 90 degree.
It is 45 degree angle.
Yeah,
if you
45.
do transperitoneal, if you do retroperitoneal, it will be 90 degree.
Okay. So what
So
will
somebody
be?
told the sodium challenge test. What is that?
Yeah.
Sodium. What is the sodium challenge test?
So, sodium challenge test says that we have to give the patient, we have to put the patient on 3 days sodium diet sufficiently, and then after 3 days we will take the sample of
which sample?
Blood sample, and we have to see that whether the aldosterone concentration is below 5 nanogram per deciliter or not. If it is a primary aldosterone, then the sodium that we give does not suppress the adrenal, and so the level of the aldosterone does not diminish. This is
What is the relation of the aldosterone with renin?
Direct relation.
Renin causes more aldosterone secretion via RAS pathway. Means renin helps in conversion of angiostensin to angiostensin 1 and further.
No, I am not going to that. When the ratio, what about the ratio of the renin and aldosterone?
Aldosterone by renin ratio should be more than 30 nanogram per ml. Then and the plasma aldosterone concentration should be more than 20 nanogram per ml. Then we can say that it is a case of primary hyperaldosteronism.
The primary or secondary? By renin and aldosterone.
So primary. Sir. Because in secondary case, the renin will also increase, and PSA concentration will not be more than 30 nanogram per ml.
So if aldosterone increases, renin will decrease. If it is secondary, renin will increase. Also, aldosterone will increase. Anything else, Dr. Rajendra? You want to ask any question?
The steps of the operation they are describing. So the port placement, how many port will you put in left side?
Sir, mostly 3 ports, sir. 1 camera port and 2 working ports.
So how will plan the port placement?
Sir, 1 camera port is a 10 mm port. The just lateral to rectus at the level of. I will imagine that I want to triangulate my area of action. So it will usually lateral to rectus in correspond to 12th rib or just 2 centimeter upper and lateral to umbilicus.
Okay.
I will put my first port. Then my second working port will be around the anterior iliac spanning umbilicus midpoint. A 10 mm port at that position. I am right-handed. My working port will be there, and 1 left-hand port at the left subcostal region at 9th tip of 9th costal cartilage.
So would you prefer a fixed port position or there is any
variable, sir, variable port position after I placed my
how it varies? What is the principle?
Sir, I will pull my area of focus And sir, I will triangulate. There will be triangulation and area of
So first port you describe is a camera port, which is placed
Sir.
approximately 22 centimeter above the umbilicus and the pararectal region, pararectus. Okay. So
Sir.
first port
Sir.
you place. Okay. Now you have to arrange these two port. One is the right port, right working port, and another is the left working port. Okay. So how we plan? So what should be the distance between two ports?
Sir,
And what
distance
is the
between two
angle
around 4
between
fingers.
two ports? Yes.
Sir, around 4 fingers. Around 4 fingers.
4 finger means 6 centimeter approximately, 5 to 6
centimeters.
centimeters.
Sir.
Yes.
Sir.
So the port distance should be 6 centimeter. And what is the angle?
Sir, angle, sir, it should be 45 to 60 centimeters, 60 degrees.
40 to 45 to 60 degrees. Obtuse angle, okay? Not acute angle. Okay.
More acute will be more difficult.
Yeah,
More
port if it's acute, then so it should be obtuse angle.
Sir.
Around 120 degree.
Sir.
And it should be on a curve.
Sir, in a curve, circular, in a semilunar curve.
In a curve, okay?
Then how will you dissect? If time is going on. So how will you dissect?
Now you enter into the abdomen. It is a transperitoneal. Okay, you are describing transperitoneal.
Just
So
steps. Name of the steps. 1, 2, 3, 4.
Yes. First
Sir,
step.
first I will mobilize. Sir, first I will
Mobilize?
go to the hilum of left kidney. Mobilize. First I
Hilum
will
of the left
mobilize the
kidney, you
colon.
cannot go without mobilizing.
In this
Mobilize
case, we
the
have to
colon,
mobilize
sir.
a descending
Colon,
column.
medial-
Descending,
Yeah,
medial
Mobilization of the colon,
colon.
number 1. Number 2.
Number 2.
Sir, medialization colon. Then I will first approach to the hilum through gonadal vein. Approaching gonadal vein, I will reach up to the left renal hilum.
Gonadal vein.
Then after reaching, sir, gonadal vein, left gonadal vein.
They want to reach the hilum, and that's why they want to trace the gonadal vein and go to the renal vein to see go to the hilum. That's okay. Okay. Then
You have to identify the renal vein. All right.
identify the renal.
Identify the renal vein and right side vena cava. Then?
Sir. Then I will search for the left adrenal vein draining into left renal vein.
Okay.
I will identify left adrenal vein draining into left renal vein. Then I will first dissect inferior and then medial to that left adrenal vein. After clipping or control of the left adrenal vein, then I will I will then dissect the more medially and superolateral.
So first control the adrenal vein.
Adrenal, sir.
We'll control the adrenal vein.
Sir.
And how will you control the arteries?
Sir, arteries mostly is the diffuse arteries usually form a capsule around adrenal. So it usually, if I am using sir harmonic scalpel, so it will usually don't take and don't need no need of any special precaution, sir. It will usually cauterize, sir.
So what are the arterial supply in the left side?
Sir, arterial supply usually 3 arteries, sir. Branch from infraphrenic artery, upper adrenal, sir. One from
You
aorta
don't
and
have to ligate any of one.
Usually it in harmonic, usually it got controlled, sir.
No, in harmonic. Okay, but why? Why it is controlled? There are 3 arteries supplying the left adrenal, and you don't have to coagulate or ligate any of the artery. Why?
So usually these arteries are less than 3 millimeter in diameter.
So these are the stellate arteries. Okay, all the 3 arteries branching and producing stellate arteries, and they enter into the adrenal around the peripheral zone. All around the periphery. So there is no single artery usually found, but sometimes you can find there is a single artery, and then you have to ligate or cleave that artery also.
Sir.
Okay, next. So you have ligated the vein, you have cauterized, you have dissected the adrenal gland, and eventually you cauterize the stellate arteries, and then adrenal is mobilized. Then next.
Then I will say deliver the specimen. Then I will deliver the specimen through the second working port and giving incision around 3 centimeter in just medial to ASIS and suprapubic regions.
Okay. Sir, anything?
So just enumerate the complication. Just enumerate the complication. Time is going.
Yeah.
Complication.
Sir, complication maybe sir due to anesthetic complication, maybe say intra complication if inadvertent vascular injury or any surrounding structure injury by cautery or by direct injury during
So
dissection.
complications for the anesthesia, complications for the access, visceral complications, bleeding, and rupture of the specimen.
Sir.
Okay, all right. All right.
And sir, sir.
Any question from you? Any question? Do you want? Any
From
question,
me?
students? Want any answer from any question? No. Sir, Professor Deka, sir. Sir, comment. Professor Deka, sir, comment.
Nothing to comment. All has been very nicely described, discussed about the case. Only thing is that adrenal incidentaloма with hypertension, hypokalemia, is nothing but a Crohn's disease because it is a small tumor. But nevertheless, any incidentaloma, you have to investigate. You have to do biochemical test and imaging. You have to do cortisol studies. You have to do the dexamethasone suppression studies, metanephrines and all. You have to do all the tests. There is no way that you can escape that. You have to look for the androgens also, because anything can be there. But generally speaking, if it is a small tumor, adenomatous-like tumor with hypertension, hypokalemia, it is most likely that it is a Crohn's disease. And only thing is can I continue, Ranjan?
Yes, sir. Yes. Yes, sir.
Only thing is that to prepare the case properly, control the hypertension and hypokalemia. The spironolactone is the drug of choice before surgery. And then you can go for the surgery. And laparoscopy is the best for this. But one thing I would like to ask the teachers and others, whether there is a place for partial removal of the partial resection of the tumor. If it is a small tumor, do you, is it mandatory to remove the entire gland? Or you can do.
No, I think in case of the bilateral cases, partial, there is provision for the partial resection of the adrenal.
So both the sides you have to do.
Yes, sir. If you need to remove from both sides, in 10% of the cases there may be bilateral lesions. Then I think better to keep. I have kept in some of my patients little bit of part of the adrenal. I don't know whether, but he is not requiring any fructocorticoid or hydrocortisone. I have followed up the patient. He's not requiring that.
And if it is bilateral adrenal hyperplasia, I think you have to treat medically.
Yes.
Yes.
Treat medically.
In
There
this
is no
particular
scope
case,
for
partial
Yeah.
adrenal can be done if it is it is doable actually.
Yes. So
In
that
this
process,
small
because
case,
sometimes the other adrenal may be absent also. Suppressed. Yeah.
Yes.
So there is a possibility that it can be done. So nothing much to add. It's a very interesting discussion this evening. All the three cases are so interesting, and discussion has been done in a very systematic way. Questions are put, and the students also, they have done a great job. And I request Dr. Ranjan to continue this endeavor. Thank you very much, all of you.
Thank you, sir.
Good night.
Sir.
Good
Thank
night.
you.
Dr. De, Dr. Ranjan De. Now, can we conclude the session?
Okay, just a minute, Siddhartha. Just a minute. Yes, before you conclude, I want to say a few words for the student. Siddhartha, I'll call you just after some time. Okay. Now, I just want to hear from the students. Today's extensive discussion on a topic which not a very common topic for day-to-day clinical practice. What do you feel? How we can improve our class? Do you have any suggestion? I first want to hear from the students because this entire program is targeted for the students, for them. So I want to hear any of the students if they give any idea that they want to have this program in this way that will benefit them more. Any of you? Any of the students? Dr. Kishore?
Sir, it is well, sir. Well, doing nicely, sir.
Is good, doing nicely. I like to request Dr. R.P. Singh, our president, if he has anything to say about today's class. R.P. Singh, sir, unmute yourself. Unmute yourself, sir. Unmute yourself, sir. First, unmute. Sir, unmute yourself. Yes. Once again, unmute yourself, sir. Sir, it looks you are not here listening to me.
Yes, I am here. I am just before you.
Yeah.
Video is
Okay,
on.
sir.
Yeah. Okay.
Tell me,
Is all
sir.
right?
Yeah. Yes. We can hear you, sir. If you have any suggestion or any comment on today's class.
Sir, admin can unmute.
I think he is muting himself every second. He is not conversant with it. Sir, unmute yourself. Yes, sir. Yes.
So, teachers are well prepared today. Students need to study some more, and program was very concise and precise. I think it's a good way to proceed. The students' feedback will be there that they should, whatever they have left, the questions were very particular. Rajesh Tiwari and all these teachers were very well prepared, and questions were in a very good way. So I think you should proceed, and we will be with them.
Okay.
They had your question was very nice. First, that what they want to improve their any teacher change, any quality change, any other things they want, we are ready to provide that. So it is
Thank
all
you.
up to the students. Teachers at this time were well prepared.
Thank you very much, sir. Sir, first of all, I want to thank my students for their active participation, and I must say they have performed very well, and they have answered almost. I have thoroughly for the last 3 hours, 2.5 hours, I have followed the program, and I found it's an excellent effort both from the students' side and also from the teachers' side. I have to thank Professor Deka. In spite of this busy schedule, he has given a lot of effort to participate in this program. Thank you very much, sir, for encouraging the students and us for conducting this kind of program. And Professor Beda, I have nothing more to say to you. Your participation and your arrangement, how the student teachers should present the case, how the cases will be discussed is excellent for future. And I am giving you the information. Just now, Professor Arun Chawla called me. He had also participated in this program. He's so impressed. Tomorrow also he will participate in the entire class. If he accepts this class of the standard they will introduce as a national program from the next week. So the students, the East Zone class will be a part of the national program from the next week. So tomorrow class will be very important. Dr. Anshuma Nasu, I will request, if you are not here, please take a full effort to prove yourself that EZone is not lagging behind at any level of urology. So I am very happy that the national, for that I have to thank Dr. Samit Swine, Dr. R.K. Gopalkrishnan for conveying this message to the national body that EZone is conducting this kind of class. Next, I must thank all the teachers, Dr. Krishnendu Maiti, Dr. Rajendra Prasad, Dr. Rajesh Tiwari, Dr. Naveen Gupta for the excellent preparation they have made. And I must confess that I have learned so much today from all three case discussion, even at this age, that really benefited my status as a teacher. Thank you very much, sir. Thank all my students and all my friends, colleagues for participating in this program. Tomorrow we will meet at the 10:45 so that we can start our class tomorrow at sharp at 10 o'clock. And Dr. Anshuman Nasu will be the moderator for tomorrow's program of the genital infection. Hope all of you will participate actively. Thank you very much. Thank you very much for cooperating and participating in today's program. Thank you, sir. Thank you. We'll meet tomorrow once again. Good night, sir.
Good night. Good night.
Good night to everyone.
Good night.